My experience had been pretty underwhelming in the context of preventive care. It was a checkup that was absent any real unique insight that I didn't really know myself. I wanted to go a layer deeper.
Celebrities like Kim Kardashian have jumped on the wave of support of a new kind of preventative care. It comes with a hefty price tag.
We're talking about Prenuvo's full-body MRI scans.
One could hypothesize that I'm a visitor from another planet, and on my planet, we screen everyone. You know, I take you back to my planet and say, well, let me propose to you that you don't screen anyone. My population would laugh you off the planet.
Why are there no major United States organizations that are recommending this?
I don't think there's any evidence that consumers consider themselves harmed by these screenings.
The burden should fall when you're testing healthy people to prove that it causes benefit rather to prove that it causes harm.
Welcome to the Checkup podcast. Today, my guest is Andrew Lacey, CEO of Prenuvo, a company that's at the forefront of whole body MRI scanning, a technology that aims to catch potential health issues before they become serious problems. You may have recently seen the company's technology in headlines or on Kim Kardashian's Instagram, spurring excitement, intrigue, and even some controversy. You see, major medical organizations, including the American College of Radiology and the United States Preventive Service Task Force, do not recommend routine whole body scans for people without symptoms or specific risk factors. There are concerns about false positives, unnecessary follow-up procedures, the cost effectiveness, and most importantly, if the proposed benefits actually outweigh the risks. Despite that, advocates of this technology argue that those concerns are overblown and that the scans can provide peace of mind and potentially detect conditions early when they're most treatable. In today's conversation, we dive right into addressing those controversies head on, as well as the science of the scans and how Prenuvo is handling being at the forefront of this emerging field. As a reminder, if you hear this sound, that means there is a fact check that is linked down below to a separate unlisted video that you could click on during or after the presentation to just get a bit more info.
You're a business person.
Yeah.
You were starting multiple businesses. I believe it was 4 at the time. And then you found a passion in treating, talking about, and fixing the healthcare space. How did you get there?
Well, the starting point really was I was a serial entrepreneur for probably the first 20 years of my career. And I was a typical entrepreneur. I didn't sleep enough. I didn't eat enough. I didn't exercise enough. I had a lot of stress. Some of those things, by the way, are still true because I am still an entrepreneur. But I remember one day just waking up and looking in the mirror and saying, you know, hey, we're doing this to make the world a better place. You know, what guarantees do I have that I'm going to be around for this future that I'm trying to create? And in that moment, I had just taken my car to a new body shop.
Okay.
And my car was asymptomatic.
So you were going for a preventive
I was going
checkup.
for a preventive checkup of my car. And what I got back from this shop, maybe they all do it this way now, but I got a 30-page report of every component in my car, the engine, the transmission, the clutch, the brake pads, the wiper fluid, you know, what was running low, where were the brake pads wearing, how was the way I was riding the clutch sort of like affecting, you know, the wear and tear on that component, how I could drive my car better, what needed to replace now, what could be replaced in the future, what should I watch? And I just had this like moment of like complete dissonance. Like, why on earth do I have this like 30-page report about my car and really understand deeply how it's performing and how it's tracking in its health? And I don't have that same picture for myself. When I look in the mirror, my understanding of my health was sort of skin deep.
Interesting.
And that really started me on this journey. So, you know, I had thought I had learned a thing or two about building businesses. And you know, at this point, I was really trying to solve a problem that I have for myself as a person. And
at that time, were you having a relationship with a primary care doctor doing checkups or not really?
Not really. I mean, I had a primary care, like most people sort of have a primary care
these
doctor.
Days, it's not most people, sadly. I wish more people had a primary care doctor.
But, you know, my experience had been pretty underwhelming in the context of preventive care. So yes, if I had if I presented with a flu or some sort of acute problem, usually I could get some relief from visiting a physician. But my annual physical usually went along the following lines. Tell me about what you do. You know, I'm stressed, I don't eat enough, I don't exercise. And the answer was generally after, some sort of cursory pushing or prodding on my abdomen well, maybe you should think about, working on your stress levels, eating better, and exercising more. And
So
I'm like,
lifestyle modifications.
which I'm not saying is the wrong answer, but it was also sort of, it was like it was a checkup that was absent any real unique insight that I didn't really know myself. I wanted to go a layer deeper.
Okay.
And that was the journey that I went on search for an answer for. And that took me, of all places, from Silicon Valley up to Vancouver, Canada.
Wow. Okay. How did that search form? Were you Googling? Were you talking to friends?
Talking to friends.
Okay.
And I had a friend of mine that had gone to TED, which is in Vancouver, and with her mother the year before, and they had heard about a doctor that was doing an early precursor to what is now the Pronuvo scan. And she had gone with her mother, and they had diagnosed a quite large aneurysm in her mother that in the week she got treated, her sister, so the auntie of my friend, had passed away from a burst aneurysm. So I just thought it was crazy that this could happen. Now, someone in the medical profession like yourself, probably that's not so unusual, but for a lot of consumers, a lot of us, we don't walk around thinking this could happen to me one day without warning.
And that uncertainty is scary.
Right. And so I got on a plane and went and got one of these scans. And back then, we used to sit down the radiologist immediately after the scan and go through the results. It was kind of scary. And I was scared doing it. What might we find? I went out for a nice meal the night before, had a nice glass of wine and said, I'm going to enjoy today because tomorrow my life's probably going to change. I'm going to get a full accounting of the abuse that I had sort of subjected my body to. I sat down with the radiologist and I learned, A, I wasn't dying of anything that I didn't know about. B, I had some really clear insights into how the way I was living my life was sort of impacting the physiology of my body. And most importantly and most profoundly, and the hardest thing to explain, was I got this tremendous feeling of peace of mind. And I came back to San Francisco, and that was the thing that stuck with me. It was sort of, I don't know if maybe some of your viewers have ever been skydiving or something. You sort of like feel like you're bouncing around with a bit of adrenaline for a couple of weeks afterwards. Or you see the world with a little bit more color. That's sort of how it felt.
Like you got a new lease on life.
I got a new lease on life. And I sort of like, I would get a headache, and rather than being concerned about what it might be, just realizing it was a headache or a stomach pain was because I ate something bad. And that voice that had been there, not always consciously, but always, I would say subconsciously, was quiet for a period of time. And I thought that was incredible. And I couldn't shake the idea that I had seen something that was potentially the future of the way we should practice medicine. So 2 weeks later, I went back and didn't leave for 3 or 4 months, and sat down with that team and met a bunch of consumers and formed an opinion that this is something that the world deserves to have access to.
Why do you think we didn't have access to it at that point? Or actually, I sort of still don't in many respects, right? Unless we're going to a private institution to get it. It's not covered by insurance. It's not in the medical establishments.
Yeah, I mean, you can do them. So here, I guess at Memorial Sloan Kettering, or, in Boston at Harvard, or Stanford in the Bay Area, you can do these scans. They're often offered to people that have a cancer predisposition syndrome. So a syndrome like Fanconi anemia. And
multiple endocrine neoplasia syndrome.
And they are covered by insurance, but they're billed at something like $50,000 to $100,000. They take 3 hours, and they often require general anesthetic just for you to tolerate the procedure of lying in the machine. So what was different here was, solving for a unique combination of hardware, image acquisition protocols to bring these scans down to under an hour so it could be offered in a sort of comfortable consumer context. And that's what this team had first done up there in Canada.
And how does the current Pronuvo scan decide who is a patient or who is a candidate? Like, for example, I'm very pro being preventive when it comes to healthcare. And, there's many tests that I offer in my practice that are sort of agreed upon screening programs that we do. Colon cancer screening, pap smears for cervical cancer, blood tests for screening for diabetes. And for the audience, when we say screening, that's generally asymptomatic people, meaning no symptoms, recommended to everybody to try and catch this problem.
Yeah.
And in the past, within at least my healthcare space, we've kind of titrated, for lack of a better term, back and forth between not scanning too many people, making sure we're scanning the right demographics so that we're not creating false positives, overdiagnosis, overtreatment. How does that play a role in the Prenuvo scan world?
Well, I think it's important to really understand the history of some of those tests that you just mentioned. So, a pap smear, which now most physicians would consider part of their standard of care screening, that was first sort of clinically validated in 1910, and it did not become part of standard practice until the 40s or 50s. Mammogram, some of the first clinical studies were in the 60s, and it was not covered by insurance until the 90s. Low dose CT screening for smokers took 20 years.
Right.
PSA, maybe that's a little more controversial, but still took 15, 20 years to be covered. So what happened in that intervening period was we saw clinical use of these tools, and that clinical use very much made the evidentiary case for these to be eventually sort of adopted as part of standard of care. And I think that's the journey that the whole body screening with MRI, the multi-parametric approach that we're doing at Prenuvo, that's the journey that it's on.
So right now, would you say the people who are getting scans are people who we're trying to create clinical validity for the future to be used in insurance programs? Like they're almost in a clinical experiment?
Well, I wouldn't say that. It's a mistake to think of this as a test. This is a clinical practice that we run. So we have a team now of 50 radiologists that collectively read these scans. We have head of specialties that work with the company. Many of these people have Ivy League education. They're all board certified radiologists in the states in which they practice. These are folks that have themselves 10, 15, 20, 30 years experience, and they themselves have evaluated the hardware and the protocols that we're using and the clinical experience that we've had over those 14, 15 years. And they've decided to come work with what they believe is a very promising technology and to play a part, not just in sort of being the, typically MRI radiologists that's the last image you get. Usually they're dealing with advanced disease.
Yeah.
And for the first time, they're actually able to diagnose cancer at stage 1 or, aneurysms or chronic disease before it even meets sort of the clinical definition of chronic.
Yeah.
So I would say there's a lot of clinical evidence behind this, and there are a lot of, we're running clinical studies in a facility in Boston. We have run retrospective studies across.
That's interesting. What kind of clinical studies?
So in Boston, we're doing a prospective 100,000 patient study that includes a large social equity component. So a large number of the people that are doing that are undertaking that trial are folks that they're not paying for the scan. They would not otherwise probably be doing one of these scans. And so we're sort of making sure that the population of that study reflects the average population. And it's a longitudinal 10-year study where we screen patients longitudinally and we follow the health outcomes. So where we saw something that we considered clinically significant disease, what happened subsequently? Was that diagnosis validated? Was that patient treated? What was, how did the use of this technology change sort of the trajectory of the diseases that we're diagnosing? And I imagine we'll report interim findings from that, but in reality, in all likelihood, that's a 5-10 year study before it really starts to provide insights into how these scans might be affecting, for example, all causes mortality.
Are you allowed to say right now that the Prenuvo scan saves lives?
We make diagnoses. We identify lesions that are confirmed on biopsy that are early stage cancer, and we would consider that those are life-saving diagnoses. Can you definitively say that about any cancer? No. I mean, can you say mammogram?
Well, I can. There's a decrease in mortality by the incorporation. Although in the past, when we overused mammograms, we've actually run into an issue of creating what we separate from a false positive to an overdiagnosis, which is a true diagnosis of a cancer, of a condition, but in a state where it wouldn't have caused a problem. Because cancer is not really, like, we use it as a catch-all term, but there's so many different styles and variations of cancer where you could have a cancer that you could have and then it spontaneously resolves. A cancer that you could have the rest of your life and you die with, not of the cancer.
Right.
A cancer that is so fast in its progression that there's not much you can even do about it. So there's a lot of cancers that fall into this term.
Yeah, I think the only comment I would make, and sort of where I was going at, is all of those studies that sort of perform those assessments are 20 or 30 year studies because the only assessment you can make is a statistical one.
Sure.
You can't diagnose a cancer and leave it untreated to see if it was a cancer that was going to kill you. You can't design a study that can sort of prospectively sort of test that hypothesis. You can only do it retrospectively through statistics, and that requires decades.
Yeah.
Yeah.
So how do you sort of balance that line of waiting for that data versus recommending the test universally now?
Well, you can sort of kind of make a circumstantial case, I'd argue. And I'll give you an example. Pancreatic cancer. So there was a study, I believe, out of Hopkins a few years ago where they essentially, I don't know the exact sort of method that they used, but they sort of like dated the tumors in patients that had died of pancreatic cancer.
Okay.
And they were able to sort of determine that the average age of a tumor at death was 7 or 8 years. And so obviously, these tumors are dividing cells that grow geometrically and acquire mutations and then eventually metastasize and so on, right? So, you might surmise that therefore that pancreatic tumor spent a certain period of time at stage 1 localized to the pancreas. Might have spent those 7 or 8 years, it was maybe like 3 or 4 years located to maybe the tail of the pancreas before it like migrated.
Sure.
And what we're finding at Prenuvo, so we've imaged now 100,000 patients, and the vast majority of those patients were imaged for the first time. So, and we're finding cancer in probably about 2 to 2.5% of patients. Now that's higher than sort of the expected incidence in the population. It's about 0.7, sort of age adjusted, 0.7%.
Is that because your test is more sensitive?
No, it makes sense because it's the first scan. And the first scan, remember there's that 7 or 8 year life of that pancreatic cancer that we're sort of catching up on because no one's looked at it before. So we expect a higher incidence and we expect and are seeing for a subsequent stand a much lower incidence of cancer detection. So sort of it's playing out the way we would expect. Where we've found pancreatic cancer, and in fact most cancers that we find, we're finding them early. We're finding them localized. We're finding them at a stage 1. In fact, we've found more stage 1 pancreatic cancer. We've found sort of metastatic pancreatic cancer. And so it makes sense that the detection window for early stage cancer is wider than it is for metastatic cancer because it spends more time in that stage.
Yeah, and also they would already be sick with metastatic symptoms and be in the traditional medical system.
Correct.
Yeah.
And that's what we're seeing. So when we find lung cancer, we're way more likely to see it at an early stage.
Well, it's because they're asymptomatic.
But we're not seeing...
Because you're separating the symptomatic and asymptomatic population and catching early things when people are asymptomatic.
I get it, but we're not seeing... so we're seeing what I think is an expected rate of detection in the 2 to 3%, given again, it's a first scan and we're picking up, we're just seeing more incidents because there's a higher cancer load that has been unscreened for previously, but we're not seeing like 10% detection. We're seeing something that feels reasonable, and what we're finding is early stage. So, so again, none of this, you might still have to wait 20 or 30 years for a statistical analysis, but like the data would seem to point towards we are catching early stage cancer at a rate that would not indicate that there's a tremendous amount of indolent cancer that's not going to eventually become metastatic.
Is not going to become.
Correct. Like the data does not support that because we would have a higher detection rate than 2 to 2.5%.
Interesting.
Yeah.
So like I look at when I, in my office, scan someone with a CT scan or an MRI for, let's say, something going on in their lungs, and then incidentally capture something on their adrenal glands, or I'm searching their abdomen for something and I catch something, a lung nodule, for example. And then I'm kind of stuck with what we call in the medical community an incidental oma.
Correct.
Something that we incidentally found when we were scanning another part of their body. And a lot of times it puts me in a really uncomfortable position because there's sometimes no guidance on what to do. Or if there is guidance, it's based on lackadaisical or improper or imperfect data. So I'm not giving perfect guidance to the patient. And also it creates a lot of anxiety. Does that happen with these scans as well, or not as much?
Wow. We might have to unpack that because there's a lot there, right? So, not to be facetious, but the whole concept of insulinoma sort of doesn't really apply in the context of whole body screening because by definition we're screening for everything. So there's no such thing as insuloma. We're looking for what we can find. And then secondly, the technology that we're using that's available today is much better than what we've had in the past, and certainly very different to CT. So we use a technique called multiparametric MRI, non-contrast MRI. And we are collecting, for example, of the adrenals, we're imaging them 14 or 15 times at a number of different tissue weights for proteinaceous tissue, for fat, for fluid, for blood, and in particular a sequence that requires specialized hardware to do across the whole body at scale like we are, which is diffusion. And diffusion enables us to digitally with the MRI look inside the body for areas of, this is going to sound very techie, high cytoplasmic ratio. And what that means in layman's terms is hard spots inside the body. And as you know, as a primary care physician, we ask, well, the guidance changes all the time, but like at a certain point in time, we ask women to do a breast self-examination. And the reason for that is, although not all lumps are cancer, all solid tumors are lumps. And so we're able to, with MRI, sort of essentially digitally feel inside the body for these solid areas. I
also think we walked back the breast self-exam recommendations.
Correct. Yeah, that's why I want to be clear because it changes. But
and it actually interesting that we did walk it back because it did create a lot of unnecessary testing that happened down the line. Similar with testicular self-exams for young men. And we kind of moved towards saying, know what's normal, but not necessarily test yourself every time because it fueled some anxiety in people.
For sure. And like I said, not every lump in a breast is cancer.
For sure.
But all solid tumors are more solid than the surrounding tissue. And that's what this scan is able to, this particular sequence is able to pick up really well. And that's pretty new. It's been around for a while. If you get a prostate MRI, it includes these sequences, but the prostate is a tiny little sort of walnut-sized object.
Yep.
And on most equipment, you can do this sequence on a prostate. The hard thing is doing it across the entire body under an hour. And that sequence combined with all the other anatomical sequences where we're filtering for different tissue types enables us to be a lot more accurate for distinguishing between lesions that are concerning and lesions that are benign. And adrenal lesions are a really great example of this. Most of the overwhelming majority of the benign adrenal lesions are fat-containing lesions, and we see that because we have sequences for it. And so when we see a lesion, we are therefore able to risk stratify reasonably precisely whether this is something that's concerning or whether this is something that is not particularly concerning at all. And we have a 1 to 5 scale, with 4 and 5 being the increasingly concerning lesions that we're finding. And typically they're followed up. So I think the rate of follow-up today, or certainly with the Prenuvo protocols, is much lower than what doctors have perhaps seen historically. That's not to say there isn't follow-up that ends up sort of finding a benign lesion, but it's just much lower than people expect.
Yeah, like I believe there was, I don't know if it was a meta-analysis or systematic review of 12 articles that looked at whole body MRI imaging, and they found 95% as a number that they used for sort of abnormalities on scans, broadly speaking. You described a scenario where you went in and you got this clear scan and it gave you peace of mind. When you had a headache, you weren't concerned. But now if you have a patient who did find something, even though you would label it as lower on a worry scale, that they have something in their bodies, now every headache is really scary. Wouldn't you say?
Well, I think that it's sort of interesting, right? Why was I not worried about the findings that I got about my car, my asymptomatic car, but I might be worried about the findings about my own health? And I have a young child. And when my young child hurts himself, or herself, I should say, she'll tell everyone on the street what's going on.
Okay.
Every single person will know about her boo-boos and her Band-Aids and how things happen and all this sort of stuff. Something happens between youth and sort of middle age where now we don't want to talk about what's wrong, the average person. We'll sort of like ignore symptoms. We'll put things off. We'll tell ourselves we'll feel different tomorrow. We will carry a tremendous amount of health anxiety. We weren't born with that anxiety. And I would put it to you that anxiety was created by our reactive healthcare system. Because if everything is diagnosed late, if every cancer diagnosis is on average stage 3 and therefore a life-changing diagnosis, why on earth would anyone go and look for a cancer diagnosis? Why would I want to subject myself to that? I'd rather live in blissful ignorance another day. So, I often tell my team, how do you know that? How do we know we'll be successful as a company? And it's easy to measure that by how many people we scan, how many patients we have, and so on. I believe we're successful when we've changed the definition of disease, when it's not as triggering as it is today, because it doesn't need to be. Mm-hmm. Learning about your health does not need to be scary. It should be empowering. Okay.
So you think it's kind of the flip side of the equation, that learning that if you have something in your brain and it might need follow-up in the future will actually reduce anxiety for people.
I think you have to, the question you have to ask yourself is, this is a different approach to healthcare. Mm-hmm. This is an approach rooted in empowering people, providing knowledge, connecting people with providers that share a similar philosophy.
Sure.
Identifying specialists that we can bring people to get appropriate care, and sort of like build a different transformative approach to healthcare rooted in proactive preventative medicine. It exists inside, alongside this reactive healthcare system. I think it would be a mistake to say, well, the reactive healthcare system has, created this anxiety, or the reactive healthcare system likes to follow everything with an infinite number of tests. And because of those characteristics, we shouldn't do this transformative preventative health approach. No. The reality is we should continue to invest and understand how these things can potentially be part of a transformed system and work to transform the system.
Yeah. What about from like a standpoint of false positives? Are you ever concerned about things popping up and it not ending up being a problem, and down the line testing and the costs and anxieties that come with that?
Well, no, for the same reason. The anxiety around false positives is a product of the reactive healthcare system, not a proactive approach to healthcare. I live in Los Angeles, and everyone in Los Angeles is talking about fires. Mm-hmm. Now I live on top of a mountain surrounded by brush. If I brought a specialist to my house and I said, tell me what's going on here, they're going to say, well, I'm seeing some pretty concerning things. You got a bunch of brush around you, mm-hmm. You don't have a good escape route. You're on a cul-de-sac. This is a big problem.
Right.
But my house may never burn down.
Sure.
So was it a bad thing that they told me what was going on? My risk, that information changed my risk profile.
I don't know.
And
is that a false positive?
That's a great question.
I think a false positive is them yelling fire when there's no fire.
Yeah. And
not warning you about risks. Because the reason why I'm a little a lot of people like to beat on our healthcare system, and I'm one of them. I'm one of the loudest outspoken critics of how we do things, especially when it comes to lack of transparency, lack of investment in primary care. But for example, there's a big, it's called Healthy People 2030. It's a federal initiative to try and get more people to go for their preventive health screenings, everything that is proven in a very high level, the higher value things. Currently, I believe the last numbers that we have from this campaign is the number has dropped to 5% of Americans over the age of 35 actually go for their preventive screenings that we have available.
Yeah.
That the ACA has made that people do not cost share with their insurance. So they cannot charge co-pays, they cannot charge money. It should be free to people who are insured. And yet 95% of people aren't going, but they're made available. So can we say it's the healthcare system that's caused that anxiety for people, or the fact that people aren't going for those things because of their anxiety?
No, I think it's a valid distinction. I can't answer that question. I do think there's a lot of misunderstanding about false positives.
Like what?
Well, as it relates to cancer, the only definitive test for cancer is going to be biopsy.
Right.
So when we see a lesion, we re-stratify it. We don't tell patients that they have cancer. We tell them that they have something concerning, and we'll tell them the level of concern we have, and we'll tell them the urgency with which we think we need to follow something up. Mm-hmm. And, we've studied that. We did one clinical study up in Canada where we followed a number of patients who ended up getting a biopsy as a result of a finding that we had on Prenuvo, and 1 in 2 of those had confirmed cancer. Mm-hmm. Now that biopsy, that 1 in 2 is that biopsy positive rate is better than mammogram. It's better than low dose CT of the lung. And it's incredible given that we're not just looking at one organ, we're looking at like the entire body. So, I think it's hard to, you have to understand how you define false positive to figure out whether we're actually seeing anything. We're not, we're just risk stratifying. And at least it seems like empirically when you do, when a finding leads to a biopsy, that those biopsies are being proven cancer, more than you might expect, or more than the average practitioner might expect from these scans.
Mm-hmm. And the fact that we're finding these things to be cancer upon saying that they're suspicious, that doesn't necessarily mean that that would have gone on to be a problem. Is that true? Because, like, for example, in Japan, they did this thyroid scan on everybody, and a lot of papillary thyroid cancers showed up. The number of papillary thyroid cancer in the country went up a lot, but the survival didn't change because it would have been a cancer that people would have not needed to treat, and they would have lived the same length of life. So, like, just finding out that it is in fact a cancer doesn't really tell the whole picture, and kind of leaves me in a complicated place on guidance on what to give patients. Does that make sense?
No, I understand. And some practitioners will say, hey, we want to wait for that 30-year, all causes mortality study to be concluded so we can really sort of have a very informed opinion about whether I'm going to recommend this for our patients. And there are other practitioners that say, hey, there's a circumstantial case here. You guys are finding cancer and disease early. We know that the outcomes for patients are better, or we believe they're better if we find these things early. And on the basis of that, I'm willing to send patients. And we have thousands of physicians that send us patients every year.
Do you make a distinction between false positives and overdiagnosis?
We don't. No, I mean, we don't. We haven't studied that in the way that perhaps that 30-year study did.
No, because the way that I think
Korea.
about the false positive rate, false positive is saying something is there that wasn't a problem.
Sure.
But in the overdiagnosis state is saying something that's truly there but wouldn't have caused the problem, which you would need a longer term study for. So, like, how does that play into a role for someone who would want to get a scan? Can there be harms from getting these scans?
Well, I guess if I follow the definition you just gave, we neither create false positives nor overdiagnosis because we don't diagnose. We just re-stratify things that we see.
But isn't that a little bit of a cop-out? Like, if you say, hey, you have something concerning, you may have not diagnosed it, but you said it was concerning.
I don't know. I think it's important to be clear about our definitions. I've got, this may be oversharing, but I've had 3 colonoscopies and 4 polyps. Were those 4 false positives?
I don't think they're false positives.
They were biopsied and they were negative.
Right. So when you take out a polyp, you decrease the risk of that polyp turning into something. So you're actively also acting
but it wasn't cancer.
On a risk. Right. Because polyps can turn into cancer.
But not all polyps turn into cancer.
Correct. So you're performing the procedure to decrease the risk.
Yeah. So I don't know. I just think it's, there's a lot of people want easy sound bites, and I think this is a complicated analysis. And to be fair, I think one of the challenges of screening is it's probably the most complicated thing to analyze the impact of.
Yeah.
I mean, it's sort of a bit sad in some ways that if a pharma company develops a new drug that makes a ovarian cancer patient live for on average 2 months longer. With ovarian cancer, that's actually a reasonably easy clinical study to perform.
For sure.
An intervention, a screening intervention that potentially, could have an impact that's order of magnitude greater, unfortunately is a really difficult study to perform. There's very little public funding for it. It takes decades to do. There's no patent protection the way there is with pharma companies. And so, patients, physicians, and the system is left wanting for, not just data, but preventive interventions. That's part of the reason why there are only 3 or 4 of those tests that you recommend. It's not just because there are only 3 or 4 interventions that probably are effective. It's because it's really, really hard, expensive. It takes a long time to study them.
Yeah. Don't you think it's a good thing that it's that hard to study them? Because we're recommending them so broadly to people who are currently not sick. So if we can cause those people harm, that's the most dangerous implication of it all. Because you're taking, for example, someone who has cancer, they have a serious problem. So I guess you're more tolerant of side effects when there's a bigger problem versus when you have someone who's asymptomatic and healthy.
I mean, I don't think there's been that meta study that you mentioned of 12 whole body cohorts. There's a German study on this. I don't think there's any evidence that the consumers consider themselves harmed by these screenings.
There's a difference between a consumer feeling that they were harmed versus where they were actually harmed. And I think the burden should fall when you're testing healthy people to prove that it causes benefit rather to prove that it causes harm.
No, I mean, I would argue that we live in a world, we live at a moment in time right now where patients are dissatisfied with the healthcare system.
For sure.
We survey patients, for example, that come to us, their level of health anxiety, 30.8% are already anxious about the state of their health, and the health system is not providing with answers. Mm-hmm. 1 in every 4 patients come to us have indeterminate symptoms that they've had for a period of time and have not been resolved by the healthcare system. Mm-hmm. We survey patients 12 months after the scan. Less than 1% consider that we made them feel unnecessarily anxious about their health and regretted the scan. So we are actually in the business of curing health anxiety that our system has created. We're not in the business of creating it.
Isn't that pre-selecting a population that wants what you have, and then you're asking them if they're happy with the thing that you're giving them what they want? Because like I have patients that come to see me that, for example, ask for opioid medications. I'm not comparing the two, but just in terms of the consumerization of healthcare. Patients come in asking for antibiotics for viral symptoms, maybe a more benign example. And I say, well, I don't think this is beneficial for you. I don't think you need this. I think this will cause harm. But if I give it to them, they'll all say they felt better.
Sure. I think there's an assumption, and maybe this is an assumption I even had at the outset, but it's turned out to be like not true, which is the patients that are coming in for these procedures are worried well. And, you know, again, we spend a lot of time surveying and understanding our patients because we want to understand, you know, how we can do a better job at what we do.
Of course, yeah.
And our patients largely fall into 3 categories that are about the same size. The first are people that want to take a proactive approach to their health. Now, that includes all those people that are vocal about longevity. Pretty much all of them get scans. But there are a lot of other quite normal people that for them, preventive health and proactive medicine is just an important part of how they want to practice their life. The same way that they might want to eat organic food or do exercise. And not all the other non-medical interventions they do have, you know, 30-year all causes mortality studies behind their effectiveness.
Just like organic food. There is no evidence that organic food does anything different than regular food.
The second category are people that have had cancer and or have a strong family history of cancer and disease. And many of those in many healthcare systems, they're given an all clear, they're given a pat on the back, and no one ever looks at them ever again. And they carry a lot of anxiety about suffering the same fate as a close relative or having a cancer reappear. And for them, not being screened is creating them a tremendous amount of anxiety. You know, it's negatively affecting the quality of their life, which is the thing that we should be measuring. And they come to us to get peace of mind. And the third category is one I mentioned, which is folks that, you know, are actually very concerned and afraid about something that they are feeling today, typically an indeterminate symptom, because the healthcare system is pretty good at resolving acute problems. And they're not getting resolution, and their mind turns to something oftentimes like the worst case. And more often than not, we are able to provide them with tremendous peace of mind that symptom that they're feeling is IBD, not colon cancer, you know, or that symptom, that headache they're feeling is not a brain tumor. It's a headache. And I think isn't that how we should be measuring? I mean, you said, you know, do no harm, but you know, by not providing these patients with this information, we actually are harming them.
Well, I think that's a little bit of a false dichotomy, because it's not you either provide the service or you don't do anything. I think when someone has health anxiety in my office, which is pretty much all the time, symptom or not, they are worried about their health, especially these days where there's so many things flagging for them. And in general, people's mental health is not at a great place in the United States, at the very least. I can speak to that, especially within my patient population. my solution isn't let me get to the resolution imaging wise, or nothing. It's I could do that, or I could also approach it from a mental health standpoint in order to treat someone's anxiety. Treating someone's anxiety with imaging isn't the only way to treat it. Isn't that fair to say?
No, but I would say, look, you're no doubt an exceptional physician too, and not all physicians are Dr. Mike.
Well, I appreciate that.
And so, I'm afraid not necessarily all of them are getting that same level of care. And there's plenty of studies, for example, showing, the fact that on average women have health symptoms that are ignored by physicians. They generally live in a worse state of health. They're not served as well.
Yeah.
And there are plenty of studies showing that.
Yep.
Do I think you, Dr. Mike, providing a worse level of medical care to your female patients? No. But when we talk about the system,
of course, we have to talk about it more broadly.
That system is not, is letting people down.
Yeah,
and
for sure. I'm just talking about how do we address it.
They come to us to help them get resolution. And many times, not always, we're able to provide that resolution a lot faster and get them to a state of knowledge about what's going on so they can then focus on treatment and improving their outcomes.
Don't you think, because part of what I do when I see a patient, and you may say this is because I'm a good physician or I'm doing something above and beyond, but I've just kind of learned to do this on the regular because it explains how we think about healthcare as doctors, knowing how much we don't know. And I think humility in medicine has been missing for some time, and we need to sort of be more transparent about that. So when patients come in and they want an all clear, I explain to them that that's impossible right away. So I set the parameters. So by giving someone a scan and telling them you're good, isn't that also kind of a false promise?
No, I think peace of mind, it's not fair to say that peace of mind is an absolute thing. I don't walk around, I don't go about my life holding any real fear that I'm going to get struck by lightning. But my chances of getting struck by lightning are not zero.
Sure.
Okay. So I don't, people that do these exams, they understand that they're given all clear. Doesn't mean that, this is a guarantee. It doesn't mean that they shouldn't do standard of care screening. In fact, we encourage all patients to continue to see their primary care physicians and do whatever standard of care screening is recommended. But it can give them a greater peace of mind. And again, that greater peace of mind is relative, not absolute.
Fair. Why do you think the organizations like the American College of Preventive Medicine, the American College of Radiology, who would stand to profit from like a whole body imaging approach, why do they say that they don't recommend it right now? Why are there no major United States organizations that are recommending this?
Well, you have to double click a little bit on what they're saying. They're not saying they don't recommend it because the evidence points against it. They're saying they don't recommend it because they don't yet have enough evidence. So they have not yet got that 20 or 30 year, study testing the reduction of all causes of mortality. And that's true.
So you're saying the scans are not yet proven.
So I'm a little bit, what frustrates me a little bit is sometimes those opinions are repeated in the consumer media. And though too much weight is given to that, people don't really understand how to pass that as a, we can't, disprove the null hypothesis. It's not, this is a scientific statement that is essentially saying we need more evidence. And unfortunately, the way what makes me a bit sad is I believe that can be interpreted by the average consumer as being, there is no evidence. It is not recommended because the evidence says this is bad. And that's not true.
Right. But the lack of evidence, again, has to be on the fact that it's proven versus saying we've disproved it.
The vast majority of health interventions that physicians practice every day do not have all causes of mortality clinical trials behind them.
Like what?
For example, we just mentioned it, like the vast majority of primary care practitioners would make recommendations about diet, for example, or exercise that are not supported by, longitudinal clinical studies.
like for example, if we lower someone's blood pressure from stage 2 hypertension to a normal range, from population studies, we can say
for sure
the decreases.
But that's one intervention. There are a lot of interventions that are there's a lot of medicine we practice. We practice because that's the way we've always practiced it.
Sure.
Yeah.
That's fair to say. And I feel like we also have something called medical inertia, which is the shitty part of healthcare.
Right. I mean,
where we carry over things that have been disproven, and it takes a while to filter them out.
And another way to put that, though, is it's a status quo bias.
Yeah, that's medical inertia. That's a good way to describe it.
You know, and you could one could hypothesize that I'm a visitor from another planet, and on my planet we screen everyone. Mm-hmm. And you come, you know, I take you back to my planet and say, well, let me propose to you that you don't screen anyone. You know. And you know, my population would laugh you off the planet. Mm-hmm. You know, so where you come from, that status quo is really important, and that status quo does not have clinical evidence behind it at all. What we do know is that we're diagnosing cancer and disease late. Mm-hmm. In our $5 trillion healthcare system, about $4.9 trillion is spent on managing chronic disease, the signs of which we can see 10 or 20 years before. And perhaps if we were diagnosing it a lot earlier, before it met that clinical definition, we could change outcomes more easily for patients. So you know, I think that status, unfortunately, you know, to prove my intervention is, you know, our intervention is the promising one, or your one, which is do nothing, is the right one. Either way, you know, you or I are going to need a 30-year clinical study. Yeah. So then the question becomes, for someone like myself who's in my 40s, what do I do in the meantime? What do I do while I wait for that 30-year study? You know, and the establishment would have you say, well, you should just stick with the status quo. And I guess my challenge would be, there's no evidence behind the status quo either.
Mm-hmm. So I don't think it's fair to say that it's either do this or do nothing.
Yeah.
I think we should be thinking about prevention and screening, where we find the biggest benefit from research, and be really careful about not overdoing it. Because even when I order blood tests, I can overdo it and make it sound like to the patient that I'm checking everything. But knowing that tests have sensitivities and specificities where I might catch things that might end up fueling more anxiety, fueling more testing that is unnecessary, I don't do those tests. And we have campaigns that have elucidated this. They're called the Choosing Wisely campaign. When I was a resident, it was like big on not ordering certain blood tests over a certain number of years because they don't change. And if they do, it doesn't help. And like even the Choosing Wisely campaign in Canada talked about whole body MRIs kind of in the same way. So I'm trying to figure out a way that we can strike the right balance, because I don't think the balance needs to be between never screen, because I think that's short-sighted, and screen everybody, because it feels like then we're going to create a problem. And in medicine, it's a unique space, and I'm really passionate about it in the sense that perfect is the enemy of good in healthcare. When you try and get something perfect, things become bad.
Yeah.
So like you try and get good, which is not perfect, but it oftentimes is better. Do you see kind of my...
Yeah, I mean, maybe we could talk about it in the context of like, one thing that we've been seeing. I'm kind of curious to know your thoughts on this.
Sure.
So when we opened, so our first clinic was in Canada, and the average age of the patient that we're seeing was 52. And when we opened our second clinic in Silicon Valley, we started all of a sudden seeing people in their 20s and 30s. Now, fast forward sort of 5 years now, we've screened over 100,000 patients, and I have a big AI team. And this big AI team is, obviously building models to figure out what a normative aging curve looks like for a particular organ or body system. So that's pretty easy to understand, for example, in the context of the brain, where, we start to look at brain volume or cortical thickness or perfusion and things like this. And they were doing, they've got one of these models for the spine. And the way you sort of expect these models to look like, it's sort of like a graph with a line that goes up and to the right. The older your biological age, the older the AI model, like the older the predicted age that the model spits out. Does that make sense?
Yeah.
And we don't tell these models what features to look at. We just say, here's a whole bunch of spines, try and figure out what
patterns are,
what features are correlated with age here. And then we can take that model once it's been trained, and we can look at any one spine and sort of like create a forecast. And maybe the idea was, can we tell someone like how your spine is looking relative to this normative curve? Are you doing better or worse than someone of your age?
Mm-hmm.
And we built this model of the spine, and when we first built it, we're like, oh, there must be some problem in the way we trained it, because it wasn't a curve up and to the right. It had a kink at the bottom. It sort of flattened out. And what that meant was that it didn't matter whether you were like the average 20-year-old, 30-year-old, or 40-year-old, everyone's spine looked like a 40-year-old. And and then we went back to our radiologist and we said, okay, we started showing them some spines from these clinics where we're starting to get younger patients. And those spines, we said, well, how old do you think this patient? And they would always say 10 or 20, 10, 15, sometimes 20 years older than the actual biological age of that person. So we surmised, and we obviously take medical history and we ask people how much time they spend sedentary and these sorts of things. And what we started to learn was for younger people that grew up spending a lot more time in front of computers and phones and so on, particularly in the cervical spine, which is where a lot of these features were being identified by the model, their spines had abnormal degeneration. They were asymptomatic, okay? They may not be ever symptomatic, or they might be in debilitating pain in their 50s and 60s.
Right.
And what we do know is that longevity is pretty close, mobility or lack thereof is, not a great thing for longevity. So the question is like, what do you do with that information? Because that's a great thing. Like,
Of course.
should I be telling someone in their 25s that they look like they have a spine that's degenerated more than it should have? It may mean nothing. You may live a perfectly healthy life. You may have a congenitally wide spinal canal, so even those disc bulges will never cause you symptoms. But maybe you want to know about it so you can do something about it in your lifestyle or not. And that's the question. And I asked myself that same question with blood tests, because as a consumer, I just found it so strange that like I have normal cholesterol until it's abnormal. Maybe there's some information that's interesting in the trajectory of my cholesterol levels before it becomes abnormal. Does that make sense?
Absolutely.
So
and I have an answer to your
understand that.
question.
Yeah.
So, and I'm really happy that you're asking me this question because I'm so passionate about this.
Yeah.
So you have this really complex AI model that it's looking at all these spines, making its own decisions about what the age of the spine is based on the degeneration. And you're finding this pattern that's elucidated from people who are sedentary, and it matches the fact that their spines appear older because of their activity level. I'm an old school doctor, I guess old soul in some regard. I would find that out by talking to the person and asking them what their lifestyle's like. And if they're sedentary, I'll tell them that it's a risk.
Yeah.
And
but the interesting thing
what
was,
changed from getting the scan?
No, and I think that's fair enough. But the question is,
So like it would need to change what I would do. And if it's not changing what I do, to me, it functions as a distraction from the actual doctor-patient thing. So what was the second part of the question that you said for blood tests? What can you do with cholesterol? I think that's amazing. And the problem is it's easy these days, especially, being near San Francisco, with people who have tremendous amount of valuable resources, excitement, that want to preserve life, want to be as healthy as they can into old age, to catch these things early. But the problem is it's never that simple, because anytime you think you've caught something early, whatever impact you're going to make there will play some sort of reflexive opposite in the human body. So the human body is so tricky in treating that every time you think you solved one problem, you've created another. And that's why, I would love to say screen more for everything. I'll give you a very specific example. There's a fashion show in New York City for Men's Fashion Week. And I forgot what the pharma company is, but they run something called the Blue Jacket Fashion Show. Mm-hmm. And I've walked in it several years, a lot of Yankees players, local celebrities from New York walk in it. And at the end, they had everyone walk up to the microphone and say, get tested for your PSA to check for prostate cancer, because it's a prostate cancer show.
Got it.
For the Prostate Cancer Foundation. When they came up to me with the microphone, I was like, talk to your doctor about whether or not prostate cancer testing is right for you. Because I think that universal screening for everything can truly create more problems. And we've seen that with PSA testing, as you've mentioned. We've walked back breast cancer imaging to some degree because we saw the negative repercussions. So to say more screening is always better than some, I feel like is not true. Do you agree?
Yeah, I don't want to be argumentative, but I would say like I don't think you can say that the opposite is true either, in the sense that
It's not true. I agree. When I
learn about my issues with my cervical spine, I'm asymptomatic.
Mm-hmm.
Okay, but I had a sedentary lifestyle, and my first company was a mobile phone company, so I spent a lot of time with mobile phones. You could argue.
Mm-hmm.
I went for my annual checkups routinely. Doctors asked me a very cursory number of questions in a very, very short period of time, and not a single person told me that I need to watch out for my spine. And I would argue that the vast majority of people for which we provide these sort of like lifestyle suggestions, I don't want to call them medical diagnoses because, again, they don't meet the clinical definition of disease.
Sure.
The vast majority of people that we provide those sort of like tips to, for them, that's a surprising insight. So the health system, unfortunately, again, I come back to maybe not everyone is like Dr. Mike. That's not a reflection. What you described, I don't think is a reflection of the average quality of care in a healthcare system which is overtaxed.
What is
that you are able in a standard 5-minute consult to elucidate the impact of lifestyle on someone's potential underlying health.
So I don't think it needs to be like a dense discussion. I think as simple as, what do you do for a living? I do this. Do you exercise? Not really. Well, if I tell you to exercise, I know that I'm proving so many variables all at one go, including your spine.
Yeah.
So while I may not focus on spinal health, the purpose is the same. And I bring this up because I've seen this with companies that offer, let's say, like microbiome testing or gut testing. I know that's not something that you're involved in, but the companies do offer that. And when I've seen patients bring in the data and they have some complex gut microbiome profile that I don't even understand, it's kind of above my understanding of it, but the recommendations don't change from the recommendations.
No, I get it. But can I just, and by the way, this is the thing I spend so much of my time thinking about, particularly more recently, is like the psychology behind good health.
Oh, okay, cool. Yeah, I love that.
And, I lived in Europe for a period of time. And, on a cigarette packet in the US, there's a big message that says smoking kills.
Yep.
In Europe, there's a message that says, something similar, smoking kills, or smoking does this to your lungs. And it has a big, disgusting picture of the lungs.
Yep.
So you might ask the question, why would they do that? Mm-hmm. And, I would argue, because I presume they're smart people, these public health folks, that a picture is a more visceral catalyst of change than
just words. And
what we find when we image people that are actual smokers, and we can show them a picture of their own lungs and the chronic inflammation caused by smoking, there is no greater catalyst for them giving up than seeing a picture of their own lungs. So it is true. A lot of these lifestyle recommendations to many people, including us as including the average consumer, are kind of obvious. We might find, let's say, small vessel ischemia in a patient for which, making sure they're in good metabolic health probably is the most important thing. Now, you might argue, well, that's kind of obvious. Like I would provide that recommendation every day anyhow, right? But patients aren't necessarily listening. And those psychological barriers are real. Mm-hmm. And they stand between us and having a healthier generation of Americans. Mm-hmm. And I wouldn't discount the catalytic power of showing someone what's going on inside their body. The same way when I got my car checked and they gave me a 30-page report, it was powerful to be able to see the sump that was leaking oil and knowing that there's a real thing going on there and there's something I can do about it.
Yeah.
Yeah.
The car thing is a tricky analogy for me because cars don't heal themselves. Cars don't have problems that are there that then resolve. Like if your tire is worn, it's worn. It's not going to
I think it's a great analogy because if my car completely breaks down on the side of the road, I can go buy a new one. If my body breaks down, I only got one.
Right. So if I scan people who are asymptomatic spines with MRI and find that they have some arthritic changes and they have no symptoms, am I going to recommend that they get surgery? Am I going to recommend any intervention? I found a finding.
I don't think you should. I mean, I think in America, there's no other country in the world that does more spine surgery than America. So I think that's absolutely the wrong outcome.
So that's the question, like more data.
But you know what our most common recommendation when we see that? Core strength. Now you might, again, it's a fair argument to say you should you work on your core
So
strength
are you
anyhow.
saying this is a motivational tool?
Why? I mean, I think the role of primary care when you're armed with this type of information becomes much more sort of practitioner coach than it does practitioner diagnostician. And I think that's where, and I think there's tremendous value unlock in that world.
What happens to an individual when they, let's say, get a scan and you say you don't make a diagnosis, you say your level of concern?
Well, we do make diagnosis of certain things. We diagnose fatty liver.
Okay, got
we diagnose ischemic changes.
But for cancer,
we diagnose degenerative spine conditions. I mean, there's certain conditions for which MRI is gold standard, and there are others for which you need a confirmatory test.
Got it.
Yeah.
So in those instances where it's not a diagnosis, it's a concern level.
Yeah.
Ultimately, it falls on our healthcare system to then figure that out.
Yeah. I mean, oftentimes, if we see a very concerning lesion, oftentimes we might recommend a patient go get a contrast exam. So contrast CT or a contrast MRI, look for vascularity around that lesion. If that in itself is concerning, then, depending on the organ, sometimes they might go straight to surgery or biopsy. And that's typical, clinical care pathway. Yeah.
If there's a range, you said 1 through 5, that you give a level of concern for these things, patients can, if they have a level 1, 2, end up going to their primary care doctor like myself, or maybe to an oncologist or something more advanced, and requesting appointments, times, more imaging, even though you labeled it lower risk. But because they have something there, they would go into the healthcare system to do that.
I mean, we do our best, and we do more than the average radiology practice in counseling and recommending a course of action or inaction to the patients. And oftentimes the right course of action for something that is benign, or even something that's indeterminate but quite small, is to just follow this on a subsequent scan. So there is also an additional tool that's available to us that is not available typically in the reactive care healthcare system, is we don't have to chase everything to the end of the earth. We can follow it on a subsequent scan. And, if there is no change, then that favors a benign process. So a lot of our patients, that's our recommendation. That's what they follow. Can a patient overreact? Of course. Can a patient overreact in any clinical context? Yes.
So you think the concern of overdiagnosis and false positives is an overblown concern in general, and that there's just so much benefit from the scans?
Well, I would argue that, there are thousands of practitioners that are referring us patients every year. And so if they felt like that it was not, and they don't get anything from this, so if they felt like it was not in the benefits of their patients, they wouldn't do it. If they felt like it created more work for them, they wouldn't do it. So these are all practitioners that have, come to value the insights that the company is able to provide, and as a result, continue to refer their patients for these scans.
I meant from like your point of view, if you feel they're overblown.
Well, my point of view doesn't really matter. I'm not a physician. The
your
point
company.
of view, the point. What I mean, obviously, I wouldn't be building this if I had a point of view that those concerns were not overblown. I do think they're overblown, but I think the more important opinion are the opinion of primary care providers. And I think it's kind of interesting that whenever we see someone speak about these scans publicly, one of the first things I have instructed my teams to do is to reach out to them and invite them in to understand what it is that we actually do. And there has not been a single physician who has spoken out about these scans that has firsthand knowledge of the scans themselves.
What do you think their misunderstanding is?
I think it's twofold. The first is screening has been tarnished by the sort of proliferation 20 or 30 years ago of whole body CT screening in shopping malls around America.
I remember the Oprah episode.
Correct. And you seem too young for that, but you're very good skin. And people have long memories, and people don't fully understand the difference between CT screen and MRI screen. As plenty of doctors have gone on record saying they don't like what we do at Prenuvo because of the radiation. And we all know that like MRIs don't even have radiation.
Could they be talking about the follow-up CT scans that might be necessary after the MRI?
I mean, they could be, but they're not.
Well, that's hard to say. They could be, but they're not.
Well, they're talking about Prenuvo. So they're not talking about the follow-up care. I mean, they don't clarify by saying that, that there might be some follow-up tests that involve radiation. And then the second thing, and this is really important and also a bit misunderstood, unlike CT, or I say like most misappreciated is that MRI is a qualitative imaging modality. What does that mean for the layperson? I mean, think of an MRI as taking photos of the inside of your body. I have like an iPhone, what's the latest generation? 16
Pro, yeah.
I got a 16 Pro. Takes great pictures of my young daughter. My Nokia phone in the 90s also took photos. They were horrible. Okay. Now, why is my iPhone taking better photos? It's a combination of the hardware, the lenses and the things that sort of capture the light. It's a combination of the software that sort of processes that. In MRI context, that's the protocols that we run, the beeps that you hear when you're inside the machine, and increasingly AI. And we have AI running inside our machines as well to undersample and up-resolve images. This is a 30-year-old technology. It has come tremendously far in 30 years. And if I'm a busy primary care provider, I don't really have, it's hard to keep up to date on how these fields have evolved. That sequence I mentioned, diffusion sequence imaging that measures hardness inside the body, that's really only been in clinical practice for like 5 or 6 years, maybe 10 years max. Mm-hmm. So if you went to medical school, 20 years ago, you may not really be up to date on how these things have sort of evolved. And that's part of the reason why we do a lot of outreach and we work to do a lot of education of physicians. And it's fair to say, Dr. Mike, that probably 80% of physicians that we reach out to are initially skeptical. But the ones that come in and understand it firsthand, more than 80% of them refer us patients thereafter. So there's a real information asymmetry.
And the asymmetry is about the technology.
About the technology and the quality of the imaging today.
Because to me, the criticism that we're talking about from some of these groups, Choosing Wisely, ACR, is less about the technology and more so about the human body and the disease process and what we do with the information.
Well, but just to double click on the technology, for example, you mentioned that meta study of 12. Part of the problem was every single one of those whole body studies used different hardware and different protocols.
Sure.
There was, a lot of the insights that we've gleaned from whole body imaging come from the UK Biobank study, where they actually did a whole body exam on some subset of those participants. And they were using what's called a Dixon technique. Now, to give you a sense, our exam is 45 minutes long. Mm-hmm. The Dixon component of our exam, 1.5 minutes. Mm-hmm. So, if I thought I could do a high quality, diagnostic quality whole body MRI exam in 1.5 minutes, that'd be great. But you can't. Okay. But that's what a lot of the insights on whole body screening have been built on top of. So the hardware and the protocols, the radiological interpretation, really, and the AI increasingly really matter.
So you think they're saying that that the technology is not good enough yet to make these scans worthwhile? Because I don't feel like I've seen that from my colleagues. Because you mentioned you have thousands of doctors that refer patients to you. But on the flip side, there are thousands of doctors, consensus groups who would say not to send patients to you.
Well, they would say that they're still waiting for that longitudinal evidence in order to form an opinion. The same way the USPT, what is it?
United States Preventive Service Task Force.
I always get tongue-tied on that one. Yeah. They're the same reason why it takes 30, 40 years for something to land on that list. and then sometimes come off the list, and sometimes come back on, and sometimes under political pressure go on the list. So, it's a messy process, but in all cases, it takes a long time.
Yeah, like I think about, are you a fan of like watches that track sleep and heart rate and all that?
I don't have one.
Well, I don't know if you were not wearing one now, but you're a fan in general. Are you? I'm curious.
I've worn them. I don't continually wear them.
You don't find them useful, or?
I find I've worn a CGM for a period of time, for 2 or 3 months, and I think there are really interesting insights that you can glean from, in the case of CGM, like there are foods that I expected would raise my blood glucose but didn't, and there are others that I thought wouldn't but did. But once, over time, the level of insight goes down, I would say.
Yeah. Yeah. I think, I try and think of myself as open-minded as can be in this tech space, because I'm excited about trying to help my patients as much as I possibly can. But at the same time, trying to be skeptical enough where I'm not just like allowing a full open cascade of new tech to bombard my patients and bombard me technically with more information that I know what to do with. Yeah. And that's my biggest struggle. And my hope is that there is more research done on this, more investment done to figure out who's the right candidate for it, when we should be implementing it. Like, using the smokers example that you gave earlier as a motivational tool, that could be a great case study use for smoking as a screening tool. Like maybe that's a better screening approach than low dose CT.
Yeah.
So like that would be really interesting to me, because then that would sort of make it targeted and a little bit more actionable, where I would feel comfortable that I'm not sending my patient for a test that could yield them harms, anxiety, further downstream testing, because it is not unreasonable. And I know a lot of people use this as like clickbait and write articles on it. I'm genuinely not that person. I hate that stuff.
Yeah.
I seen patients that have some suspicious nodule, end up getting some procedure, getting their lung collapsed, end up with a chest tube placed, chest tube gets infected, they're in the ICU, and I'm just like, holy shit.
Yeah.
What it taught me in healthcare is that ultimate 100% control doesn't exist.
Yeah.
And the more I can help my patients become okay with that and do what we do have good evidence for and stick to that, the better I think they will feel ultimately, because they will have less anxiety and they'll have better performance. Will I prevent all cases of all preventable cancers? No, I don't. I think when I try and do that and exhibit that much level of control, I think that's when we start hitting that perfect milestone and getting the negative repercussions of it. I'm just curious what you think of my mindset on that.
Well, I think I also am challenged, but I'm sort of challenged by this myself, because we are sometimes sort of grouped under the category of like longevity interventions or medicine. And I struggle personally being the CEO of a longevity company.
Okay.
Because when I see the sort of people that speak about longevity, I don't see myself in those people.
Who are you thinking of when you say that?
I don't want to name names, but you probably know who I'm talking about.
Interestingly enough, not too long ago, Brian Johnson was sitting in this seat. So, and he actually posted something recently about whole body MRI, I think with actually one of your competitors. So
yeah,
we won't name them,
but I just think longevity in some ways, in my opinion, he's actually doing a lot of good educating folks to some extent, but I think more broadly, it sort of needs a rebranding, because, I generally try and live my life sort of 80-20. I don't have 10 hours a day to focus on being healthy. I'm running a company, I have a young child, and a whole lot of stuff. So like, what are the...
And what does it mean to be 100%?
Right, exactly. Well, yeah, like do these, spend an hour in an ice bath and, whatever.
I think all this stuff is within reason, right?
Right. But I think that when people think about the longevity movement, I don't know if I'm saying that right because I'm Australian. Is it longevity or longevity?
Longevity, yeah.
Longevity. Mm-hmm. That's what they think of. That's they're thinking about all this crazy stuff. They're thinking about Peter Thiel, like injecting, the blood of young people to live longer and stuff like this. And I just think that does a disservice to what I believe we need, which is, try and identify, continue to research and identify a series of interventions that get us a lot further along than where we are today. And you and I might argue about what those interventions are or what might be the evidence to sort of like arrive at where we feel comfortable sort of like recommending one thing over the other. But I don't think it's 100 things. But I do think it's more than 3 things, which is what we have today. And we've got to figure out what those other things are, because I think if, solving that is a required step in transforming, this reactive healthcare system to something more proactive.
Yeah. I'm also curious from the motivational standpoint, how to get people, because again, a lot of the research that's done in this space is done with people who are already self-motivated, which really biases the research, because a lot of my patients that come into my office are working 3 jobs, have multiple children, have life problems, don't have a lot of wealth. I work at a community health center. They're not looking for massive amount of prevention. They're not the Silicon Valley type. So how do I get those people to come in for the free? This isn't even a financial thing. This thing is free. It's paid by the government, but they don't come in for it. So like, how do we start even there? Because if you think about 95% of age 35 or older do not come, it's not 3, but the limited amount of preventive care that we do have evidence-based medicine calls for, they don't come in for it.
Yeah.
That's to me, like, if I'm trying to pick up the most weight possible, I'm focusing on that boulder.
Well, I have a hypothesis that we're sort of testing somewhat in this trial we're running in Boston, because we do have this sort of social equity component to it. There was a study in the UK a while back where they looked at sort of the average clinical pathway, what it took to arrive at a cancer diagnosis. And I don't like it that we keep talking about cancer, because I think what we look at is a lot broader than that. But like, it's sort of interesting in this UK study. I think it was something like it took on average 6 months from presenting with symptoms at the GP to a diagnosis. And it took also something like 12 visits to GPs and specialists.
To make the diagnosis. Now, national healthcare system makes it hard.
No. There are more similarities than there are differences between healthcare around the world. Okay, that's a political. That's just politics. It's the same in the US. Now, if someone presents with, again, like indeterminate abdominal pain, maybe nothing, could be cancer. Who is going to arrive at a diagnosis faster? The upper class worker who can take unlimited sick pay and time off to like chase things out fast, or or someone who's working 3 jobs, has 2 kids, no childcare, and struggles to is constantly canceling their doctor's appointments because their kid is sick. Who's going to arrive at diagnosis faster?
The person who's more motivated, more time.
So this, one of my hypotheses is that these comprehensive scans are potentially a shorter path to diagnosis for the people, like potentially an equalizer for the people that need it the most. Because in our healthcare system, what I believe is that, once you're diagnosed, there's no better system in the world than the US healthcare system to like get treated and get resolved. But the biggest disparity is happening in getting to diagnosis. And maybe these scans can actually help right some of that disparity where they're more widely available. So that's part of what that study is designed to prove, or not prove. But I think that's a hypothesis that's worth checking.
Yeah, I think that's interesting. My question is, if we go down this hypothetical, how realistic is it that those patients who don't have the time, who work these jobs, pay $2,500 out of pocket to get the test, and then what happens treatment-wise after?
Look, it would follow that test would have to be provided for them. I'm not suggesting that they would pay out of pocket. But what the clinical study is designed to look at is to see, what is the impact of this testing do on that cohort of patients that otherwise wouldn't have access to it. Mm-hmm. So there's always still a question of how does it get paid for? Who pays for it? Is it covered or not?
And can they access it?
And can they access it for sure? But putting that aside for a second, what impact does it have? Because you're right. I mean, getting some of these folks to to come in for one appointment is really difficult. But it's easier to come in for one appointment than it is to come in for 12.
So you're saying the time savings of it all.
100%.
How
or
many-
maybe they come for those 12, but it takes them 3 times more time. So, that average in the UK of 6 months, I mean, it is what it is. It's an average. There were some people that got diagnosed in 20 days, and there were some that took 200 days.
Right.
So, but also for those people, again, I try and think of both sides equally. They'll come in for less appointments because they have the one, but then how many more follow-ups do they need? Because we are scanning everything and there's a higher rate.
Well, and let's distinguish between what type of follow-up we're talking about. So there are essentially 2 types of follow-ups from a Prenuvo scan. The first is we diagnose something and there is follow-up in the course of treating a condition. So for example, if we find severe fatty liver with fibrosis, there is follow-up 100%, but it's follow-up because it's a medical diagnosis. What you're really asking is like, what follow-up is there that might be required to, confirm or not an indeterminate finding? And we're studying that. And what we know from clinical experience is it's much less than people think.
Yeah, I would like to see where that yields, and realizing the fact that a diagnosis was made and there needs to be a follow-up for it is also interesting because, again, just because we made a diagnosis and there's evidence for it anatomically or on a cellular level doesn't necessarily mean we need to take action.
But sometimes
cases.
that is bringing for, in some ways, there might be more follow-up today, but what we're really doing is bringing forward a medical diagnosis that would have happened tomorrow.
At times,
Yeah.
or it would have been never found or impacted their life.
Yeah, there's lots of hypotheticals.
Yeah, that's what I'm saying. Like it's important to consider the whole picture. I try and be as holistic as possible
I
with
know.
this kind of stuff. And I know it's hard to hear it because
It's hard to be declarative either way. I
Yeah.
think that's the challenge with health. Like you said,
Yeah.
I mean, I think you made a very good point, which is like our bodies are very complex.
Yeah.
That whole
Complex, and our control is limited to some degree. So I'm trying to figure out how we exert control in a valuable way where we're not overdoing it, but not underdoing it, and finding that balance. And, people can very respectfully have a discussion about it, where that line falls without any kind of dramatics involved with it, because people will have different risk tolerances. Like someone will say, oh my God, you go rock climbing, you're going to fall. The risk is immense. I would never do that. Both are reasonable people.
But I think that's where I sort of land, which is to say, okay, absent, conclusive evidence one way or the other, a lot of this, until that moment arrives, what we can and should do is inform patients of the potential benefits and the potential risks of these exams. And if they...
Well, it's hard to know that until the research has been done, the longitudinal research.
No, I mean, I think we've just spent the last hour talking about some of the potential benefits and the potential risks, right? So I think...
But potential is kind of a cloudy term here because we don't know what the long-term data would show, right?
Well, I think on the benefit side is potential early diagnosis and better outcomes. I think the counterpoint would be potential overdiagnosis and or false positives or treatment or something like this. I think that's... I mean, I don't think you'll ever get more precise a discussion than that.
Yeah.
And I think...
But it's so important to figure out which way the scale goes, right? Because if you just tell a patient, well, like, look, we could be over-testing you, or we could be catching things early. Both are valuable, right? Like in terms of you want to not over-test and you also want to catch things early. But which way is the bar graph higher, I guess? Are you finding more things early and are intervening and prolonging life? Or are you catching a lot of things prematurely, perhaps over-testing and causing harm? Until that's
I get that.
yeah.
But then, maybe I'll finish the sentence for you. Until that's elucidated, do we think it's the practitioner that should be making that decision on behalf of the patient? Or do we think that we should do our best to inform the patient and allow them to make a decision?
I think it should be a shared decision-making approach, which is kind of where we land with a lot of these screening protocols. I mean, the PSA is a prime example of something that we used to recommend, and now it's in the shared decision-making approach. When a patient approaches me as to whether or not they should get scanned, it's based on their case, what's going on with them, what their mindset is like, what their family history is like. But
it's hard to universally say that everyone should get it.
And I think
but I
those-
think as a
yeah.
business model, you kind of have to say that.
No, I think that's exactly those thousands of practitioners that refer us patients. Those are the conversations that they're having with their patients.
Yeah, I'm curious if they are, or are they just saying like, we just see so much benefit in this, we're believers and we're sending all our patients.
Well, I mean,
I'm curious.
I
and I
can't-
you
no,
don't
no,
know
I
the
can't-
answer.
I can't
You
speak for them.
that. Yeah, that's my curiosity, right?
You know, Dr. Peter Tia talks about this, and
Yeah.
he talks about informing patients, and he is very, you know, he has a you know, a monologue about the benefits and, you know, and the types of patients that could benefit from or not benefit from whole body screening. And so I think,
I also think he has a partial ownership of an MRI group for this.
oh, I'm not aware of that.
Yeah. So like, again, very
Not us, to be
complex.
clear.
Yeah, exactly. I think he talked about it on one of his shows, but it makes it a little bit muddy. And I'll tell you one thing, like out of this
Well,
whole,
none of those thousands of practitioners that refer us patients have any ownership.
Yeah,
in us.
exactly.
Yeah.
I'll tell you the one thing that like, if I'm to be the most skeptical and cynical of the entire process is one thing, and I'm curious how it lands for you being in charge of it. When I see a celebrity make a statement that this test saved my life, when Kim Kardashian very popularly posted for you guys, when Kim Kardashian makes a statement in the healthcare space, from my experience with my patients, it is 1,000x more influential than when an academic journal publishes something meaningful. So it's concerning to me when that type of celebrity advice, which is very case study, very influencer driven, is guiding my patients' decisions. And I worry about that. Do you ever worry about that?
I mean, I personally see the benefit of some of those folks speaking out in just raising awareness that these technologies exist. And I think it's appropriate, I mean, once someone learns about this, to speak to their primary care provider to understand whether it works for them. If a patient doesn't have a primary care, so if someone comes to us that's not referred, we have a process. We work with medical practitioners that do a appropriate review for every patient to understand whether there are any contraindications, to understand the reasons why they want to get the scan.
What would be a contraindication?
For example, pacemakers or
Metallic
certain
stuff.
neurotransmitters, things like, yeah, exactly. Typically implants,
Got it.
metal in the eye, things like this. We ask all of our patients why they want to come in for a scan. That part of that appropriateness review is to understand if we are the appropriate test for the reasons that they want to be screened.
What would be a reason that they would say something on that answer that you would turn them down?
For example, if someone's primary concern are, I have constant splitting migraines and I want to figure out what's going on, we would probably recommend that they go get a dedicated head MRI. And we don't do those.
But I remember you said earlier in the conversation, there's a lot of people who have non-specific symptoms that find diagnosis as the third
sure.
group of people.
For sure. And that's not, I mean, I think it's a gradient. Now, sometimes people have symptoms and they're also looking for a holistic health checkup. So every one of these is evaluated on a case-by-case basis. And I think, I don't know what the percentage are, but a certain percentage of folks are referred or sent or suggested that we are not the right test for them. They should go get something else.
Got it.
An example might be patients that have had cancer within the last few years. We don't often consider ourselves to be an appropriate test, or we will not perform that test without having a primary care provider actually write us a referral. Because we do not want to substitute for whatever might be the treatment plan or care that their oncologist is sort of like directing. So we do have, I mean, it's a clinical practice. Our radiologists have, every time they sign a report, their license is online. So, they are trying to be very careful about, what makes for, what, as we start to think about what are the criteria and medical appropriateness for the exams. Yeah.
How often from that standpoint do you think about, because you said you're very interested in the psychology of health and wellness. Like I know the way that I speak to a patient about their condition, I can make them exponentially more worried about the condition or less worried depending on the language that I use. You're familiar with that? Like,
Yeah.
I guess,
Yeah.
logic. So if I tell my patient, oh, this is a very scary condition that could end up with this symptom, it could metastasize, whatever. Like I could use words that would make it sound scarier to a patient. When someone of social influence says this thing saved my life, I see my patients get very worried about their own health, and it fuels their anxiety as if they're not doing something or we're not offering them something, as if they're being let down by us.
Yeah.
That's my struggle with the celebrity influencer of it all. And then like, I'm pretty sure you guys don't pay people for advertisement, but you give them free testing.
We sometimes do, yeah.
Because like disclosures and all that, how do you handle that?
I mean, we comply with whatever are the laws, and I mean, we operate in different jurisdictions. So, I mean, I'm not. I actually have a law degree that I don't use anymore. Okay, but I'm not the lawyer. So, you know, I have a team that makes sure that we sort of typically appropriately inform.
Well, I'm curious. Did Kim Kardashian
consumers
pay for her test?
That she came in as just a regular patient.
So she paid for the test.
Yeah.
And Paris Hilton, all these celebrities, they're paying for their tests out of pocket.
I mean, I don't run it, so I'm not sure who paid and who didn't pay. But like many people come in and pay and don't talk about it. They have big audiences. There are folks that come in and pay themselves, and they want to talk about it because it had a profound impact on them or their friends. And then the reverse is true. There are folks that, I mean, we don't tell people what to write about us. There are folks that we think it would be interesting to educate them on what we're doing. Some of them might be physicians or non-physicians, and sometimes the most likely outcome is they don't ever say anything about us at all.
Yeah. The reason I'm just such a skeptic is being in the business and seeing the influencers. Like I know what Kim Kardashian charges $1 to $2 million a post. So to see Kim Kardashian make a post, say not an ad, that's worth $2 million. I mean, you guys aren't UNICEF, right? Like a nonprofit company. You're a for-profit company, and she's giving you guys $2 million worth of advertising. It's just strange. Like, why is that happening so often with celebrities?
I mean, I'm sorry to say again, and I don't want you to take this personally, Dr. Mike, but I think it generally reflects a disillusionment with the medical system in general, and that people feel like they are, you know, the system is not working for them.
So you think a person like Kim Kardashian doesn't have a system that works for her?
No, I think she understands the context of the American health system, and she has a tremendous audience. And if she feels like sharing the news of this, you know, this exam with her audience can potentially change outcomes for those people, why not do it?
Interesting. Well, because I would love to see it be done to get 95% of people who aren't going for their preventive
maybe I wish I don't unfortunately have her in my phone, but I'd be happy to connect you with some of these folks. I mean, I think that's 100%. The first, you know, I do a lot of podcasts, and you know, it's a rare podcast that I don't say, do your colonoscopies, do your mammograms, do whatever is a standard of care testing. It's really important.
I'm curious, as my last question to you, for you were living this quote unquote less than healthy lifestyle because you were founding companies, serial entrepreneur, and then you had that test done in Canada. What lifestyle changes did you make after getting the test done?
A couple. I would say the most profound one for me was, the worst findings I had were with my spine. And the most profound change I made is I now work at a walking treadmill desk, and I walk about 10 miles a day.
Nice.
When I'm at home. And it works for me. You know, it's, I stand a lot straighter now. My posture is great. I never used to be able to even just stand on 2 feet for like, you know.
That's awesome.
Stand up, you know, without sort of wanting to shift my weight onto 1 foot for, you know, after more than a couple of minutes. Now I could stand on both feet for like an hour. And so it's been really, really helpful. It's a small thing. Yeah. You know, and it's for me, it's an intervention that I can do without changing
your world,
my work,
and
you
still
know?
Be busy. Yeah.
I do have to tell people when I'm on a call that I'm walking on a treadmill because I have this like sway. And then I have at my workstation, I've been experimenting with one of those like pressure plate, the vibration plate things.
Oh, cool.
For which I think there is way less science. But I someone gave me one.
But super benign.
So I thought I would try it. And now I have to tell people that I'm on one of these things because I think I'm just cold.
Okay, makes sense. So you said walking was one, and then what you said two?
I mean, changes? I would say I just got more conscious about my diet. And I do, cool. now I'm down to 2 meals a day, oftentimes 1 meal a day. I don't do breakfast anymore. And this was mainly not because anything was particularly diagnosed, but I've got very great abdominal muscles from having sucked in my stomach for many years.
Okay.
And the great thing about MRI is you can suck it in as much as you want. You can still see it there on the image.
Yeah.
And what I noticed in myself, and I mean, this is well studied as well, is that men, before I think their mid-40s tend to carry their weight subcutaneously. And then once you hit mid-40s, 50s, you start to bring it, somehow comes inside and it's visceral. And I see that on my scans. And that for me was just a big kick in the backside to practice, going 14, 16 hours without eating, as many days as I can.
Yeah. And that's a great strategy for some people, especially if some people wake up without a huge appetite in the mornings. I think it's really reasonable because people argue with these different camps. Oh, I am intermittent fasting. I'm keto. I'm this. I'm like, look, whatever gets you to consume less and you could stick to it and you're not over consuming some harmful ultra processed foods, great.
But I grew up with, breakfast being the most important meal of the day, and I think that's probably one of the biggest lies that have been told to us forever.
Yeah. I look back at the history of medical mistakes and realize we have to have a lot more humility of saying what we don't know.
Yeah.
Because when we come with utmost certainty, I feel like that's where we run into problems. That's why I'm always so skeptical and trying to see both sides to try and do my best to not repeat the mistakes of the past.
Yeah, no, I think it's great the work you're doing. And I'm just excited. Hopefully from the conversation, you can tell, we take it really seriously. We're a clinical practice. We're trying to, we're also a startup business that's 5 years old, and we reinvest as a business everything that we make from these scans in furthering the technology and in doing research.
Yeah.
And I'm really proud of that as a company, and as is our clinical team. And while we work to establish, that sort of the evidence, the all causes mortality study, we just can't sit on our backside and do nothing for the next 30 years. So we're running, we're looking very carefully at the objections that people are making around anxiety or around downstream testing or around sensitivity and specificity and things like this. And we're designing clinical studies to see if we can address each of these objections and sort of build, in the meantime, something of a more solid circumstantial case. Yeah. Does that make sense?
Yeah.
And bring a little bit more data to a discussion that is a bit absent of data, or has historically been absent of data on both sides.
For sure.
Yeah.
I also see, and maybe you can't answer this because you can't speak for other companies. I know there's other, obviously, people doing similar work, and obviously everyone has their own technology, different software, et cetera.
Yeah.
Do the major organizations ever reach out and say, we'd like to participate in that research, be a part of the research? You say it's hard to patent screenings. Is that something that you guys have patented? Is that possible for the NIH, for example, to come in and say, we'd love to use your technology? Are you open to that? A lot of people watch this channel. Right? We had the vice president on 3 days before the election.
So. Love to talk about it. I would love to find a way to accelerate the evidence gathering. The real challenge is, think about like mammogram. That was, adopted after clinical studies covering something like 2 to 3 million people, I think. There was a lot of evidence gathering that took place.
And internationally.
Yeah. And so we perform a scan that costs, $2,500. So if we wanted to do a standard clinical trial with 2 million people, I should say, at $2,500, that would consume the entire budget of the NIH.
Well, the cost hopefully goes down when you're at 2 million people.
Not as much as you would think.
No?
Because the biggest cost here is radiology.
Well, maybe with AI in the future.
Yeah, I think that's one of the areas we reinvest in is looking for ways in which AI can speed up the scan, can help help radiologists be more productive, and deliver insights to clinicians that are difficult for radiologists to do because maybe there's small, subtle changes over time. So yeah, it's a big part of it. But yeah, there's a lot of, it require a lot to run a study of 2 million people.
Sure.
And I'm not sure that I would hope the new NIH, if it's still around, it will be sort of funding that sort of study. But absent that, we do what we can in clinical studies that we run. And we are collecting evidence in the ordinary course of building out a clinical practice and running studies and then hopefully bringing those results to people like yourself so that, every year that decision that you're making to recommend or not recommend these scans can become a little bit more informed.
Mm-hmm. Do you, because, we talked about the American College of Radiology, are you facing that same criticism, potentially doubt from other nations' healthcare systems? I know the British Medical Journal has written a little bit about overdiagnosis, but what about abroad? Or are you primarily United States?
I can't really speak very smartly about this. I understand that there are some countries like Japan or Korea where image-based screening is a lot more prevalent and common. I know that there are countries in the Middle East that are looking to do population level studies around this. So there's a willingness to really lean in, I guess. I think most of the developed countries are sort of the Western developed countries are a bit consumed by just how overworked and, just all of the other more pressing problems that are presented by this reactive healthcare system to have sort of the mental bandwidth to even think about doing things differently.
Got it.
Yeah.
Okay. Well, look, I appreciate your openness, transparency, and excitement for having this conversation. I get really nerdy about all the science of it. So thank you for your time. And thank you for the work that you're doing and trying to create more research in this space where we desperately, desperately need it.
Thank you, Dr. Mike. Appreciate it. Cheers.
All right, let's leave you with my final thoughts after this conversation. First of all, a big thank you to Andrew for coming on to discuss the topic and allowing me to state my concerns openly and have a civilized discussion. I have to say, I'm certainly intrigued by the technology and am in love with the concept of catching diseases earlier so that we can have more success with treatment. However, I am still not sold that this is what the Prenuvo scan has proven to deliver. In the day and age where we find ourselves, folks want more out of healthcare than we can yet deliver. I'm not surprised that thousands of doctors are referring to Prenuvo, given the pressures that I know doctors face to be up to date with the most groundbreaking tech and the rise of consumerization in this world. Patients, especially wealthy ones, often come with a list of demands, and that consumer pressure can impact the doctor's decisions, especially when the harms of that decision aren't well established and the benefits sound potentially revolutionary. Unfortunately, if we're being brutally honest, the term revolutionary in this regard really just means unproven. And when it comes to unproven interventions in healthcare, I am wary. Barring emergencies, if I don't have clear data for the harms and benefits of an intervention, especially one that is meant to be used on healthy people, I cannot widely recommend it. Offering a test that can catch so many diseases early while our Stone Age healthcare system falters behind sounds like a great deal until you have to wrestle with the complexities of how the human body works and understand how simple statements like "we caught cancers early" can be highly influential and deceptive, even if not done intentionally. On a positive note, I am confident that we will create new prevention and screening guidelines in the near future. There will be new technologies paving the way here. Perhaps Prenuvo can be a part of that, especially with AI improvements that can help narrow which patients would actually benefit from a scan. But at this time, for me, these whole body scan programs are more of a mix of health curiosity and clinical experimentation as opposed to proven medical interventions. In fact, I think the TV show Scrubs said it best.
I am considering offering full body scans here at Sacred Heart. What do you think?
I think showing perfectly healthy people every harmless imperfection in their body just to scare them into taking invasive and often pointless tests is an unholy sin.
Does sound a little sketchy ethically, doesn't it? Thanks, Barry.
How about new tech that can actually save your life? Check it out, click here, and as always, stay happy and healthy.
$51,000 people will die at minimum if we don't change the law. We don't renew the ACA. When you talk to a mother and she says, my daughter has cancer and she's going to lose her treatment, my daughter's going to die. That's a moral imperative, not a political imperative, a moral imperative to do something about it.
I think the reason why our channel is successful is because we try and see people who disagree with us, their side of things.
Yes, good
so
idea.
What's your understanding as to why the Republican leadership is okay with making these cuts? What is their plan? In the past, I've said that my content is clinical, not political. And I realized that's inaccurate. In order to advocate for my patients, in order to advocate for good quality public health, we need to be political. The key is to not be partisan. Currently, the United States is in the midst of a historic government shutdown, all centered around healthcare spending. So I invited Senator Chuck Schumer to a conversation where I challenge him on the truth about why the government is shut down, what impact it has on your life, and how your health premiums may skyrocket in the near future. Please welcome Senator Chuck Schumer to the Checkup podcast. Senator, thank you so much for joining me at a time where it seems the entire world wants to hear from you. Thanks for coming on the Checkup podcast.
Mike, I couldn't think of a better place to be. And I know, you know, how strongly you have fought for healthcare things. We've had some successful battles together. Yeah. There are EpiPens on airplanes, every airplane, because of us. We have more doctor slots because we're so short of doctors, especially primary care. And we did those fights together. Yeah. And now, you know, now I'm involved in another healthcare battle, a very important one.
Yeah, so for viewers that might be confused why we're having this conversation on the Checkup podcast, it is because healthcare has become the main reason for why the stalemate exists, why the government shutdown exists. Right. And I want for us to have a conversation today that is not MSNBC, CNN, just transparent, honest about what's happening, because people are frustrated, Senator. They're confused. They don't know what a government shutdown is, why it's happening. So hopefully we can tackle some of it today.
Terrific. Love to.
Well, let's kick it off. The government is currently shut down, going into week 3. What does a government shutdown even mean? Because when I ask my patients, my friends, my loved ones, they say it. They say, oh, some essential things are happening, but some are not. Some are not getting paid. So what's happening?
So like a company, a government has a budget. Mm-hmm. Our budget expires September 30th, okay? And what has always happened in the past is that the Democrats and Republicans, because you need both in the Senate, unless one side has enough 60 votes, which no side really gets, supermajority, we sit down and negotiate. This time they didn't do that. The Republicans said, take it or leave it. And the Democrats, we felt that what's happening in healthcare, that the healthcare crisis is upon us, and Americans are going to, so many tens of millions of Americans and families are going to feel such pain, that we said, we want to negotiate to address the healthcare crisis. So they said no. What's the consequence? I'll get into all of the details as to why they said no, and most important, what we're fighting for.
Sure.
But what it means is that the government doesn't have money to spend. Essential services continue and the people work. They don't get paid, but they get paid. Everyone who is furloughed, whether you're working or not, gets back pay at the end. So no one loses any money, but it's hard.
Of course, yeah.
We hate the shutdown. That's why we want the Republicans to simply sit down and meet with us. So essential services, the military, law enforcement, air traffic control, they continue to work without pay. Some other people are furloughed, and they come back when the shutdown is over. And then they all, what the Trump administration, they've done something no president has tried during the shutdowns, to fire people. But that's illegal. And they've been doing that all along. Shutdown or not, they take agencies and they illegally fire them. In most instances, those who are fired in their groups, unions or whatever, go to court and win, but they are using the shutdown as a pretext in that regard as well.
And when these specific essential workers that are not getting paid, that get back pay, how has President Trump funded some of their pay? Because he wanted to make sure some groups continue to get paid.
So he funded the military with $8 billion. He took research dollars out of the Defense Department and put it into pay. Now, that's probably not legal because Congress allocated the money in one place, and the Constitution says the president can't just unilaterally move it without Congress's okay. But he's been doing a lot of illegal acts to enforce what he wants. Everyone wants the military to get paid, of course. We need them. They risk their lives for us. They're just great. But the way to do that, the real answer, is for the Republicans to end the shutdown by sitting down and talking to us. This is unprecedented.
So are they not talking to you?
Not at all. Listen to this. So when we saw how they decimated health care in June in their so-called Big Beautiful Bill, which is we call the Big Ugly Bill, and by the way, Donald Trump said, we better change the name because it's not very popular. They thought it would be more popular than it was, but the way they slashed lots of things, not just health care, but energy costs, your electricity bills are going to go up dramatically because of what they did, because they eliminated some of the best forms of producing energy, clean energy, wind, solar, but health care in particular. We said to the Republicans, way in advance, let's sit down and negotiate. And we started in July, and Thune and Johnson, these are the two Republican leaders of the Senate and the House, said no. And we wondered why. And then in late August, early September, I don't remember exactly when, Trump said, we don't need the Democrats. Well, of course they do, because he needs 60 votes in the Senate, and they got 53. I was wondering what his math was like. And so they didn't try to negotiate. Finally, we did get Trump to sit down with us. We asked Trump to sit down with us. Once we found out that the two of them wouldn't do it because of Trump, we asked them to sit down with us. We asked Trump to sit down with us. He said yes. And then the next day, you may remember, he said no because Johnson said don't do it. But he finally did the day before, but it was too late and he didn't have a serious negotiation. And
What happened during that meeting? That was in the Oval Office?
It was in the Oval Office, and he saw, well, two interesting things happened. First, he didn't take it that seriously. He was playing his games. You know, he put these Make America Great red hats on the desk. Of course, we didn't put them on.
Oh, he was recommending that you wear them.
Well, I think so. He didn't say that, but he had some aide come over and put them on
little
the desk.
gamesmanship.
All of that. But here was the interesting thing. When we told him how bad this crisis was, how people's health care costs would dramatically rise so they'd have to lose health care, he said, that's going to be bad for me. I think it was the first time by his body language, et cetera, that he realized how bad the crisis would be. And it's, you know, he is going to see that more and more and more, because we can get into this. Over this month, people are getting from their insurance companies notices of how much their premiums will go up. Mm-hmm. I just make one other point, if I might.
Please.
When I was majority leader, we had no shutdowns. We did 13 different budgets. Why didn't we have shutdowns? Because I sat down with the Republicans and I said, look, no one's going to get everything they want. Let's come together and make an agreement. And that's how budgets are passed. And that's what happened. Trump is the first time with the Republican leaders, unfortunately. In the old days, if a president said that, some of the Republican leaders would have the backbone to say, no, we got to do this. This is how. But they went along with Trump. So it's the reason we have a shutdown is they won't negotiate with us. And it's common sense when you have two sides that each need something, you sit down and talk about it.
So in reflecting on that, do you feel that the Republicans have been more successful this time around, that perhaps maybe you should have held firm and had a shutdown during your course?
The number one reason we are not doing this, we are not, the number one reason we feel so strongly about health care is because it's decimating. And let me give you some details.
When we say decimating healthcare, what will actually play out?
So they slashed Medicaid by $1 trillion. What does that mean? First, it means rural hospitals all across the country, mainly in Republican states and districts, are going to close. Some have closed already because so many of these hospitals depend on Medicaid. Mm-hmm. For many counties, like including in some of my counties in upstate New York, they're the only hospital, and they're the largest employer. Mm. Second, this applies to lots of your audience who I know tend to be young folks. The parents who are in nursing homes are going to get kicked out. Mm. I was at Silver Lake Nursing Home on Staten Island, where I know your dad lives. Mm-hmm. The owner told me if these cuts go through, all 300 patients, many of whom are Staten Islanders, are going to have to leave because I have to close. I'm 70, 80% Medicaid because Medicaid pays for the people in the nursing homes. Where are they going to go? A lot of the kids here don't have an extra room to put them in. And even if they did, as you know, as a doctor, they can't provide the kind of health care they need. Mm-hmm. Even more devastating is how the premiums will rise. In other words, we want to just renew the tax credits that have existed for a while. on your ACA, your Affordable Care Act, or they used to call it Obamacare. If they are not renewed, and we asked the Republicans 3 times, we put votes on the floor, and 3 times they voted no, unfortunately. Here's what will happen. The average American who's on ACA will pay $500 to $1,000 more a month. Not a year, a month. That's, $6,000, $10,000 a year.
That's budget breaking for most families.
Exactly. That's the problem. They're going to sit at the table Friday night and get their insurance company's new proposals. They get them this month. By October 31st, every state requires the insurance companies to send it out, I believe, just about every state. And you'll see it'll be devastating. For older people, it's even worse. A couple making a couple that's 55 years old, 2 people 55, who makes like $85,000 a year, which is not that much, particularly with 2 people working, making 40 or 45 each, $25,000 increase. So these people, and they're starting to get the notices. You see, the people didn't start getting notices till October 1st. And about 12 states have gotten the notices so far, but it's going to be every state by October 31st. What are they going to do? It's like an economic punch in the stomach. I have 2 kids. I can't afford $15,000 more a year. I only make $60,000, $70,000. Am I going to have no health insurance? What am I going to do if my kid gets sick? What am I going to do in these situations? So this is one of the most severe and devastating cuts in health care that we have ever had. And we feel an obligation to represent the American people in this trauma. And even if you don't have, your Medicare will go up because of deficits. If you have Medicaid, you're in real trouble, of course. And it's not just poor people, and I believe in helping the poor people, of course, but it's middle-class people too, because of nursing homes and stuff. But even you have neither Medicare nor Medicaid nor ACA, your premium's going to go up a lot because the insurance companies have to make up the money they're losing somewhere else. So this is going to be certainly the worst crisis in healthcare for as long as I can remember.
I think the reason why our channel is successful is because we try and see people who disagree with us, their side of things.
Yes, good idea.
So when I sat surrounded by those who were anti-vaccine, I had a debate against 20 individuals. I wanted to hear them out. I wanted to understand where they were coming from.
Yeah.
What's your understanding as to why the Republican leadership is okay with making these cuts? What is their plan?
They say we'll have a plan, but they don't say what it is. But for so many of them, they've hated this from the beginning. Many of them opposed Medicare and Medicaid when they started in the 60s. Before the 1960s, we didn't have much health care in America. You were on your own. Every Western country had it. And there was an outcry, and under Lyndon Johnson, we've had Medicare and Medicaid, and we've advanced it and made it better and better and better, making it easier for people to afford their health care. But a large group of Republicans have never wanted to do it, and it's these MAGA right-wingers. And they just hate having the government involved in helping people. But the average person without health insurance, without Medicare, without Medicaid, can't afford it, period. It's gotten, as you know, more expensive now because, and look, it's not a perfect system at all.
I mean, it's far from a perfect system.
It's far from a perfect, but people are living longer and healthier because they have the resources to get the kind of medical care that you and millions of other doctors and healthcare professionals give them. So here's the horrible thing. They would rather not negotiate with us and shut down the government than provide this health care. It's almost a religion to some of them. And it's horrible. But they're against the American people. Here's an interesting little poll statistic. I don't usually like to cite these polls. Extending these ACA premiums, which will dramatically cause the rates to rise for everyone that they can't afford it, or they have to sit down and say, oh, God, I'll have to really cut back. I can't go to the doctor or hospital I want to go to. I have to pay much more in copays and in deductibles.
Which is devastating because then the emergency room becomes primary care. Emergency rooms lose money. They close. People can't get care. It's bad for everyone.
It's happening already. Emergency rooms are closing. Community health centers, which, as you know, are the cheaper way because it's not a big hospital. It's like a drop-in clinic. They're closing left and right. It's terrible. And so this is just something we feel we are doing our job and representing the American people. And what I was telling you was, so extending the ACA credits, over 90% of Americans want it. But here's sort of the interesting thing. 55% of the people who voted for Trump, so they're hardly bleeding heart liberals, want it extended. So the Republicans are misreading how bad this is. But day by day, more and more people are getting these notices. By October 31st, everyone who has any health insurance will be getting these notices. And it's already, when I go out around my state and other states, this is what people are talking about. And it's going to, people, you know, our hope is, and more than hope, our belief is, strong belief, that this is so bad that people, Democrat, Republican, Independent, will go to their congressmen and senators and say, fix it. This is a crisis for me and my family, and I think that will happen. It'll take a little bit longer, but as more of these notices come out, and here's the one other thing. On November 1st, you got to make your decision starting November 1st. Do I eliminate health care for my family? Pay more, as we talked about, more deductibles, more co-pays? What do I do? So we got to move fairly quickly.
Yeah, there's been a heavy sticking point for the Republicans surrounding health care for illegal immigrants.
Yeah.
They've said that time and time again, and I'm going to play it out how I've experienced the information coming at me, and I'd love for you to reflect on it. Initially, it was Mike Johnson coming out and saying, we don't want illegal immigrants to get funding dollars from these ACA subsidies.
Right.
On the flip side, you come out and say, that's illegal. We do not provide Medicare ACA subsidies to those who are here illegally. And they say, well, yes, but if they use the emergency room or if they get some kind of protected status, that bypasses those rules that you're saying. Is my understanding correct? And what else am I missing?
Okay. Number one, this bill, what we're fighting for is health care insurance. Medicare, Medicaid, ACA. Not $1, not one effing dollar can go to an undocumented immigrant. That's the law, and they haven't shown a single situation where it happens. Now, maybe they can find something by accident or something.
I believe it was KFF said something like 1% of that budget will go to getting healthcare for illegal, undocumented individuals, because if they end up in the ER, for a really rational reason, because you're not going to ask for someone's immigration status when they're having a heart attack,
right?
Because you won't get that answer, especially if they're unconscious. So based on our rules that we have, the EMTLA, we have to treat everyone in the ER.
And your Hippocratic Oath.
And Hippocratic Oath. We would treat those patients.
Yep.
And some of the spending from that budget would go there.
Okay.
Is that true or no?
No. Here is it's let me just modify what you said.
Mm-hmm.
This is a law that's passed in 1986, signed by Ronald Reagan, because people were being turned down from nursing homes, mainly American citizens. I mean, not nursing homes, from hospitals and emergency rooms, who said, you don't have insurance, go somewhere else, and they die. So this has always had bipartisan support, that people who show up in emergency rooms, in real emergencies, you know, a real answer here, we shouldn't have people going to emergency rooms unless it's a real emergency. And that's why these community health clinics and these rural hospitals are so important. And you shut those down, it's going to have more people go to emergency rooms for non-emergency situations. And so when someone shows up, American citizen or otherwise, in this emergency room, and they don't have insurance, different people have different hospitals have different ways of paying for it. Some pay for it by different programs, okay? Some pay for it by state and local, and a lot of them pay for it by charity.
Yeah, so, we have a charity care system where I work.
Exactly.
Yeah.
So that's what happens here. And this idea that illegal immigrants are getting this money is crazy. Crazy. You know, I can't...
are any of those three programs that you mentioned part of the spending bill that's currently holding?
No, that's the point here. Whatever they want to say about this 1986 law, 1968 law, maybe they want to change it. It has nothing to do with the debate we're in. And I want to say nothing. Again, no Medicare, no insurance, no Medicare, no Medicaid, no ACA goes to illegal immigrants, period. Why are they doing this? It's because they always try to divert attention away from the real issue.
But that's
If they were
politics
to-
in general. It's
I know,
hard to
but,
say that.
but
they,
Mike,
them.
this is so serious. It's always politics in general.
And depending on which party you ask, they'll say this is serious for us. We believe our budget
Okay.
is so bad
Well,
that this
I'll
is
let
serious.
I'll let the American people
Well,
decide.
for sure, yeah.
And they are totally, 68% of the people are on our side on this issue. 40% of Republicans are on our side. And they're on our side not because it's Democrat, Republican, not because it's a political fight. They don't give a hoot about politics.
Sure.
They're facing these devastating decisions they have to make. Ahead of a rural hospital, should I close my rural hospital? They had a Silver Lake nursing home on Staten Island and many others. Should I close my nursing home? And then, of course, the tens of millions of Americans are going to have to make the decision as to whether they pay more. So the bottom line is they always try to come up with a subterfuge, a diversionary issue that has nothing to do with what we're debating and discussing. And here's just this is a little political insider-ish, so shut me off. The real roadblock here is Johnson. Okay, not Thune, although he's not been helpful, but he hasn't. Johnson is in a true pickle for two reasons. Number one, about half his caucus doesn't want any ACA extension. Scalise just got up and said that. That's his number two guy from Louisiana also. So they don't want it. But he's got 50 people in his caucus who very much want it, and they're the ones who are most vulnerable in the re-election. Everyone, they want to keep the House Republican. We want to see the House go Democratic under Hakeem Jeffries. And so he's stuck. So his decision, what he thought, he would pass a bill without talking to us that didn't address this issue at all and jam us. And in the House, he can do it because he doesn't need Democratic votes. But in the Senate, he does. And they thought they could barrel us into just saying yes. We have found the American people, our constituents, the people we're supposed to help, feel so strongly and are hurt so badly on this that we said, we want to negotiate, and they wouldn't. And they'd rather shut down the government than help these people. It's just crazy.
Yeah, you've...
And it's because of the political pickle that Johnson is in. What's the way out of it? Trump. Trump, he's pretty good at the politics of all this. As much as I despise so much of what he's done with his politics. I mean, I worry about our democracy, but that's a different subject. We're not going to get to that today. But when Trump backs Johnson, Johnson usually then backs off. And Trump is seeing how bad this is for him politically. The two best Republican pollsters, a guy named Fabrizio and a guy named, I think it's McLaughlin, I forgot it's one of MC something. They both said that Republicans will lose the House and lose the Senate if they don't change this, because it's the most devastating consequence to American people that we've had in a very long time.
Why? You've made unpopular decisions before.
Sure.
That you thought were right.
Yes.
You made your speech on Israel, which some people disagreed with.
Well,
you chose not to shut down the government earlier in the year.
Speech on Israel, I criticized Netanyahu for the very reasons now that other people are criticizing.
I'm just giving a couple
I thought it was the right thing to do.
Yeah, so you follow your heart.
Yes.
Why is it so important on this issue to follow your heart?
51,000 people will die at minimum if we don't change the law, if we don't renew the ACA. Tens of millions of Americans will have, the biggest issue. You ask the average American family, what bothers you the most? It's nothing political. It's costs. It's how much practicality, but how each week with my income of X do I buy all the things and have all the things I need, right? And it's gone way up. It's probably the reason Biden lost the election. They called it inflation, then now we call it costs, but same thing. And now Trump is in worse shape on that issue than Biden was when Biden lost the election, in part because of the tariffs, they've raised costs, in part because of what they did on energy, that's going up. But the number one reason is health care. And so the bottom line is I felt an imperative to do something about this. When you talk to a mother and she says, my daughter has cancer and she's going to lose her treatment, and the research, the groundbreaking research has been cut off because they cut off NIH, something you know better than anybody. My daughter's going to die. That's a moral imperative, not a political imperative, a moral imperative to do something about it. So I felt this was the right thing to do. And the good news is virtually my whole Democratic caucus, from the most liberal to the most conservative, feel the same way. But most important, it's not my caucus. It's the American people. I mean, 2/3 of these cuts are going to be in red states and red districts. I don't care. And, you know, some people say, don't get this done and it'll be good for us politically. It's too important to get this done because so many people will suffer and thousands will die.
Thinking from the Republican side of things, Thune yesterday offered you to buy some time and allowing these ACA subsidies to continue temporarily so that we can reopen the government. Tell me about that.
He didn't offer it to me.
Who did he offer it to?
Nobody that I know, but he's supposed to offer it to me. But he didn't offer it. He said he might do it, but he said he first he wanted us to just go along and not negotiate, do what they want, you know. And then second, maybe we'd negotiate when we see what it is. We need to sit down, the four of us. That's how this has always been done. Jeffries and me on the Democratic side, Thune and Johnson on the Republican side, and negotiate something that addresses this issue. Will we get everything we want? No. Will they get everything they want? No. But that's how it's supposed to work. Thune talked to the press, but there was nothing real, and he never talked to me about that, and didn't have any concrete proposal either. It was just sort of in the hallway.
Yeah. Given that you're saying you believe Johnson is leading the real issue here,
He's the roadblock,
and that President Trump would be on par with this, we're Brooklyn guys. Trump's a New Yorker, I guess, sort of. You have your flip phone. What's stopping you from calling him up directly and talking about it?
Look, when I met with him, when Hakeem and I said, Mr. President, when you're ready to sit down and talk with either the two of us or better, the four of us, the four leaders, we're ready to do it. He hasn't yet. Now he's had his things. He's had his negotiations in the Middle East, and he's doing this with Zelensky. But I believe that the American people, as days go on and we get closer and closer to October 31st, will make it so clear that they want this, that Trump, I think there's a good, strong likelihood that Trump goes to Johnson and said, let's solve this problem. It's very bad. He'll say politically, I don't know how much he cares about everybody, all the people, but he'll think that.
The average person listening or watching will see the president of France, Macron, call President Trump on his cell phone to cross the street.
Yeah.
But you won't call him to talk about this situation?
If I thought he'd have a serious negotiation, I would.
And you don't think he will?
I think he will, as at the right moment, yes.
So you're waiting for the right moment to have that conversation?
Well, yes. We have to have the right moment. You know, if I were to call up and he'd just call me names, which he does and doesn't bother me.
But you guys have a kind of a cordial relationship when you see each other. There's smiles,
I wouldn't
there's
say
handshakes.
cordial. I'd say we have a Brooklyn Queens relationship.
Okay, that's fair.
Okay.
How long does this go on?
Well, look, this Republican shutdown, we hope will end soon. And we hope it's because, as I said repeatedly, but I believe it. This is my job. My job is to represent the people of my state and every senator and every Congress, the people of their communities. And I believe that every day more and more people are seeing, you know, on October 1st, very few people saw how devastating the crisis would be. But in the 12 states, for instance, there was some article in one of the papers today, in the 12 states where they've gotten the notice, there's a groundswell. By October 31st, all the states will get the notice. And I believe the pressure on the Republicans, particularly a lot of the Republicans who are not MAGA, and they'll say, save us, we're going to lose our seats if you don't do this, will bring the Republicans to the table, negotiate, and we can get something good done.
It's so frustrating as an individual listening to a conversation like this, probably, because it seems like everyone in politics is making these decisions based on mounting pressure, based on re-election campaigns, as opposed to what's truly right or moral.
I'm making it because I hear, and I think my colleagues are making it, the bottom line, we hear the anguish of people. That's my number one motivation. Now I find, you know, Abe Lincoln said public sentiment is everything, which means the people ought to decide, and they ultimately do. We still have the vestiges of democracy, despite Trump trying to undo parts of it. And I believe that will happen. I do. And my motivation, my sole motivation, is to prevent this awful crisis from happening. I don't want to go down the street and have people telling me how bad this is and they don't know what they're going to do and how are they going to deal with their parent or how are they going to deal with their child. Health care is, probably the most important thing to the American people of all the things the government does. And it's at risk. As I said, since the 60s, we have built up a healthcare system. Is it perfect? Far from it. But is it a lot better than it was when you couldn't get any insurance and people were just, and the life expectancy was whatever. You would know the number better than me, but much lower than it is now. And to undo that and turn the clock back, I believe I would be not fulfilling my responsibility to my constituents. When I see that mom talking about her daughter dying, when I see that middle-class family saying, what am I going to do with my 82-year-old mother who needs help in a nursing home? When I talk to medical researchers and they say, we're on the verge of coming through with a breakthrough on Alzheimer's or pancreatic cancer or these things you know better than me, and now it's cut off, I'm motivated to act.
Yeah.
And I've always felt, I think I've said this to you before, the higher you climb in politics, the fiercer the winds blow. So when you're a senator or a congressman, the winds blow pretty fierce. If you stick to your own internal gyroscope, and my internal gyroscope says, help the people, do what the people want and need, that's the way to go. That's what I've always done. Mm-hmm. And as you said, sometimes it's unpopular. In this case, not only is it the right thing to do, but it's helping people, and people every day, more and more people get these notices. More and more people hear their nursing home is closing. More and more people hear their rural hospital is closing.
1 to 10, if you can give me the number first before you answer, how worried are you that the Republicans will use the nuclear option to remove the supermajority on this?
Well,
number first.
Low.
Okay. They've done it with judicial nominees.
They've done it in a few instances, but removing it altogether would be a huge deal. And, I have a lot of friends on the Republican side, and I don't think they could even get the number of votes to do it. I think there are a good number of Republicans who say that would undo the whole bulwark of the Senate. And so I don't think Thune wants to do it. Now, sometimes he's pushed to do things, and he too often goes along with what he's pushed to do, even if he knows it's wrong. But in this case, I think there's a pretty deep feeling among the Republican senators not to do it.
Mm-hmm. Why were they comfortable doing it with the 40 or so judicial nominees?
Because,
I believe Democrats did it in 2013 also with nominees.
Nominees have been somewhat different, and I think this would be on the most major issue facing us. To do this in a way that would affect all future legislation is way beyond what happened with nominees, as bad as that was.
Mm-hmm. You made a video recently on social media basically saying that Johnson is more worried about the release of Epstein files rather than what's going on in the emergency rooms and hospitals. Was that just politics, partisan theater, or do you really
there's
mean
something really going
that?
on here, okay? First, everyone wants the Epstein files released. It showed leaders of our country and government doing all kinds of very bad things and then covering it up. So even the MAGA people, you have so many of these MAGA people getting out and saying they should be released, okay? Johnson would not release it. Trump wouldn't want it released. And Johnson, I have found to be a very political animal on most of these things, or too many of these things. And he's from a very conservative district. By the way, his district, this is another thing, his is one of the highest districts in losing healthcare dollars in the country, because Louisiana doesn't do that much for healthcare. Anyway, so there's something called, it's just very arcane, but it's called a discharge petition. And if you get 218 congressmen to sign the discharge petition, it has to come to the floor, and then it would pass. Okay. There are now 217 who have signed it. And there's a newly elected congresswoman named Grijalva from Arizona. Her father passed away, and she was just elected to the seat. And you bring up another point that I got to make. If she is seated, there's 218, and the whole Johnson and the whole Epstein files are released. I have it in the video that we talked about a minute ago. That's one of the main reasons. The point I should make now is Johnson has not had the House in session for 3 weeks. How do you negotiate a deal if none of them are around and no one's talking to each other? Why? First, because he's afraid of bringing this to the floor, and he thought he could bamboozle us into doing it. But now he's seeing they've had 10 votes. In each case, it's been the same vote, and they keep doing it over and over again. But second, he's afraid of the Epstein files, because if he brings the Congress back into session, he's going to have to swear in Ms. Grijalva. It'll be 218, and the Epstein files will be released. So he's got both those things going, and it's despicable. It's disgraceful that here we have this healthcare crisis. Here we have people really going to suffer and die and be sicker longer. And well, what's the best thing we have? Our health. And he's doing this for political purposes. So yeah, I did this video to knock him a little bit, to put a little pressure on him.
Mm-hmm. One of my friends the other day asked, isn't the reason that this shutdown is ongoing because Senator Schumer is afraid of AOC primarying him and he wants a distraction? Any truth?
Zero. I'm doing this because I think it's the right thing to do, period.
Mm-hmm. What do you tell the general public who's frustrated with losing trust in our nation? I mean, when the government shut down, that can't bode well for other nations taking us seriously. Right. What reassurance do they get?
If we succeed in dealing with this healthcare crisis, I think people's faith in the country will be greater. I think if we don't deal with this crisis, the people will be even more distraught. They'll say WTF at the dinner table, if they're allowed to say that at the dinner table. And they'll say, this is the most important thing to me, and they couldn't fix it. I mean, again, it appalls me that Republicans would rather shut down the government with the harm it causes. We hate the shutdowns. I've always not liked shutdowns, as you talked about my earlier vote. Mm-hmm. Months ago, before this healthcare crisis started. But they're going to say, they're going to say, how could they let this happen? Especially, it's not doing something new. The difference here, we're not trying to take something away. We're trying to just keep it as it is. And as it is, as I said, could always use improvement. But going back to where we used to be, with no health insurance for tens of millions of people, is awful, mm-hmm. Horrible.
So if they do make this concession and they join you, would you give them credit for doing so?
Yeah, sure.
Yeah, the three issues that Republicans and I think a lot of Americans are really concerned about: wars, the budget, the fact that we're so in debt, yeah, exactly, and illegal immigration. Given that the policies have changed so abruptly, targeting those perhaps who are here illegally, there's less incentive for people to come here illegally, and there's been decreased illegal immigration happening under President Trump. Do you give him credit for that?
No, what he's done on immigration, I think, is wrong, and he's done it in a vicious way and also a haphazard way, arresting people and sending them without due process. We have due process and process of law, so I do not. We should have a good, strong immigration bill. And actually, we came up with one last year where there was a bipartisan bill. It would have stopped illegal crossings of the border, it would allow more legal immigrants to come into the country. And it had the support of a lot of Republicans, even Thune. And Trump said he wasn't president yet. Don't do it because I want to do it. Mm-hmm. He has not fixed this system at all. Mm-hmm. Okay.
Thinking about the deficit, them trying to fight back and push on this healthcare spending, trying to lower the deficit. Is there any rhyme or reason to cutting the deficit through focusing on healthcare cuts, given the fact that our healthcare system is so bloated?
You know why they did it? Okay, I'm glad you brought this up. Where did the money go in this budget where they cut $1 trillion from healthcare? Tax cuts for billionaires. Now, I'm not against billionaires. Billionaires are like the American dream. There's some poor people in America who start out poor, work their butts off, and they get to be a billionaire. I'm not anti-billionaire. But they don't need a tax cut, particularly when it comes with such devastation. But they have a small group of very wealthy people, billionaires, not, newly made billionaires, who don't want to pay taxes. So one of the shibboleths of one of the watchwords of the right wing is we got to lower taxes. But who are they lowering taxes on by and large? The richest people in America who have a lot of political clout because of the money in politics. So yes, the deficit is real, but the number one reason they did this, was to give tax cuts to billionaires. That is far less important than saving the healthcare system.
What's your relationship like with these billionaires and these billion-dollar companies when they come for your re-election campaign and they donate $250,000? What do you say to them when they want you to go to bat for them as opposed to your constituents?
I say, if you're right, I'll agree with you. If you're wrong, I won't agree with you, period. And that's what I've done.
So that's all they get when they make a donation?
They get me to give a fair look, but nothing more.
And then the final third of that conversation is about war. Do we give President Trump credit for creating peace in Gaza?
Well, look, I have always, and I've been critical of Netanyahu, as you know. I've always said what we needed above all was a return of the hostages. Mike, I flew to Israel. I'm the highest ranking Jewish elected official in America. And right after October 7th, a week later, I was the first elected official to fly there and tell the Israeli people, we have your back. And I met with the parents of people. One lady showed me a picture of her son, like 11, 12 years old, on a motorcycle, grabbed by these Hamas thugs, waving goodbye to her. She was waving goodbye to him. That picture stayed in my head every day. There was another parent there who knew their son's arm was blown off, and would he survive? And another parent who was there, we sat in the room talking, said, I'm a doctor, and oftentimes when there are these, you would know this better than me, the wounds can be self-healing. So freeing the hostages, and I've gotten to know their families pretty well, is really important. And also getting a ceasefire. Look, the devastation that has occurred to the Gazan people has been awful. And I criticized Netanyahu repeatedly for the way he conducted the war. I thought they could have done more to minimize civilian casualties, as much as I think Hamas is a menace and danger, and without Hamas, we have a much better chance for peace. And getting more aid in, not using food and basic substance as a way. So those two things have been accomplished. And look, there are a lot of people who deserve credit. Trump, other people, the Arab nations, some of the others, they deserve some credit. But we have a long way to go. And there's a real opportunity here, Mike, because I believe, and one of my severe disagreements with Netanyahu, even back then when I spoke critically of him, I wasn't critical of him wanting to get rid of Hamas. That's a good thing, because they're such a vicious, evil thing, and they've been standing in the way. But to be for a two-state solution. The Saudis want a two-state solution. The Saudis say they're willing to come in and rebuild, a lot of the devastation in Gaza, put in help with their financial resources, their being the leader of the Sunni Arab world, and their wealth, put in a moderate Palestinian entity that maybe 5 years from now or 10 years from now could govern in a Palestinian demilitarized state. That's the hope. So we have a long way to go. But the door has been opened by this first agreement, where a lot of people deserve some credit and pats on the back. But we got to keep at it. And one of my jobs will be pushing everybody I know, whether in Israel, in the Arab world, or Trump administration, to not stop here, because we could revert back to the old way, but to get this two-state solution, which is going to take a lot of work and a lot of effort and a lot of compromise. But ultimately, if we could get two states, this 75-year-old traumatic war, and I so believe we need in Israel, could actually bring some stability finally to the region.
Yeah. As a doctor, I worry about the aid that is now perhaps not being sent to Gaza, to the people that are in this war-torn area. So I hope that continues.
Yeah.
Because that's suffering for children, for
Yes.
families. That's
Yes.
that's absolutely devastating.
Yes.
The reason why I just wanted to explain why I'm pushing so hard to give credit where credit's due at times.
Yeah.
I know it's difficult in this political landscape because everything can be weaponized. Every soundbite can be weaponized. That's the era we live in. But I feel like the general public is getting tired of these gotcha, taken out of context, AI, deep fakes.
Yep. They did one on me. Trump just did one on me.
I saw the
yesterday.
Republicans yesterday put out a video.
They always want to come up with some diversion as opposed to anyway. Go back.
So the reason why I'm saying it is because I feel, and I've been quite vocal about this for the medical organizations in my world, AMA, AOA, whatever alphabet soup you want to throw in there. The more we can be honest, transparent, even if it looks like it's weakening our position, long term, I feel like it fortifies trust. So that's why when I'm giving you these three scenarios, perhaps that we could say President Trump is doing some things well, so that we can come together a bit more.
In my statement, I gave credit to a lot of people, but I included Trump.
Which some people refuse to do.
And I got some criticism for it, but so be it.
How much are you in agreement with your party on the current state of the shutdown? Bernie Sanders?
Everybody's on board on this from one end to the other. That's why they've had us vote 10 times. They thought they could pressure us, bamboozle us, threaten us, and they haven't. And the vast majority of my caucus and the vast majority of the House caucus is, and the reason is we have been very proud of building up the healthcare system and letting people get decent healthcare, and we don't want to see it undone, particularly and in one fell swoop like they did. So we feel, as I said, it's a moral imperative, it's a people imperative above everything else.
No effing way, as you said.
Right, I said that.
And you got a lot of positive feedback from your party that you're standing up for this issue. Is there anything within the party not related to the shutdown that you guys are having disagreements about right now? Or is everyone on board fix this healthcare crisis first?
Well, I think there are some people, I think overall we want to fix it first. Everyone agrees we ought to negotiate. Now look, a negotiation, when the Republicans realize that they should sit down and talk to us, and Johnson realizes he ought to bring Congress back. I tell people federal workers are working and not getting paid, and House Republicans are not working and getting paid. Federal workers are working and not getting paid. House Republicans are getting paid and not working. So I think we all agree that we should have a negotiation. Once we have that negotiations, there may be, some people may want a little more, a little less. But we have to solve the problem.
Yeah.
That will be the watchword.
Well, Senator Schumer, I appreciate you taking the time to debunk all this misinformation, set the record straight. To conclude, I'd love if you will, and feel free to pass if you're not comfortable doing this, to our camera here. Pretend you could send a message to President Trump. What would you like to say to him? He's listening right now.
President Trump, the American people are suffering because of the cuts in the so-called big, beautiful bill. When I saw you, you seemed to understand, there was body language and all of that how bad this is. Get Johnson and Thune and perhaps you to sit down with Jeffries and I and negotiate a real way to get out of this terrible problem.
Senator Schumer, thank you so much for your work.
Great to be here. Thank you. We've done some good things together.
Huge thank you to Senator Chuck Schumer for making the time to speak with us, to speak with you, because these issues really matter, and telling it like how it is very valuable. But you know who doesn't tell it like how it is, scientifically accurately or otherwise, is Secretary Kennedy, RFK Jr. Check out this video where I talk about all the dubious medical claims that he frequently touts, and as always, stay happy and healthy.